Yes.
Yes, ma'am.
All right, thank you for acknowledging. So, so just before we start our topic, just a few discussion, a random discussion. So, how was the mock test? Did you realize that you need to work hard on some specific areas, or you all did well, really well in the mock test? Can we have feedback from anyone?
I was not able to register, so I am waiting for PDF test.
All right, so definitely the PDF will be shared, and you can just go ahead with it.
Yeah, I'll
The
try inshallah.
reason, yeah. So, Sidra, are you the one who is giving in September?
No, I am for January, inshallah.
All right, inshallah, inshallah, definitely. And I can see Paris. Paris, did you attempted the mock test?
Yes, Dr. Aqsa, I realized that revision is very important.
Yeah, exactly.
And I was so much depressed after giving.
No, it's just like to have you get motivation and take it as an encouragement for you. You know, you just need to revise the things. Once you'll just go through it, then you'll be able to revise it quickly than the first
Yes,
time you read it. Yeah, because your points will be highlighted. You will have written some important points in the corners. Try to take the print out of the guideline rather than in the laptop, because it makes your eyes so much fatigue in the light. It's difficult.
okay.
Sapna, did you attempted the test? Especially for the September candidates, I'm really worried for all of them. Because for January we still have some time. But for September, we want you now to be more enthusiastic towards your studies. Now, no more
Yeah,
laziness.
actually, I attempted the test, but yeah, the as Paras said, it, I also couldn't complete it properly. Like there were multiple wrong answers. Uh, and I was planning for September, but I got a mail that this time I couldn't get in. It's postponed for 2021.
Okay, no worries. You know, January is not so far. Still, you have some time to go. You can have still some time. But especially for the September candidates, you know, they need to like boost up themselves now. A very less time is left, because now the exam is turned into be an online one. Now you don't need no, you don't need to have to struggle for the visa purposes. You either you have to go to Karachi, Islamabad, or somewhere who is living anywhere in the country, in different countries. Now you don't have to go with this struggle. Now this is being over. They've just simplified it, making it easier. The RCOG is facilitating all the ways through to us to get through these exams and get the degree. Now we need to all put our efforts and make it done. And who else did attempted the mock test? Any feedbacks from them, please?
Actually, there were some 5 sets of questions, and I attempted 1 or 2 questions, and then somehow it got stuck, and then it showed me the result as 2 out of 40. I just did 2 questions, and the second, I couldn't understand how it worked, and actually, I could do only the third set properly, it seems.
Or
Um,
maybe the
there was
connectivity
some,
issue may be there, but definitely what we can do, we all mentors will decide a date, and we can come up to a date and discuss all the questions of the mock test on the live session. We can discuss this so that everyone can have any confusions are there. You can just clear up yourself. That is why we just put only the SPAs were there. There was no EMQs in this mock test, just to motivate, so that you're able to do it and get to onto the right track from now onwards. Definitely, we'll do this. We'll consider this and make a live session for that very soon.
Okay. And once I tried to do it in my mobile, but it was not showing the full screen. Only half of the questions were visible. In laptop it was okay, but I couldn't do that in the mobile. Only half of the questions were visible. I don't know whether it was the fault at my end. I don't know, but there was some issues like that as well.
Yeah, maybe we can we'll just go through it. I'll inform my IT team about it, and definitely they will look into this matter as well. Yeah, and Ahmed, as you're asking about the registration, yes, definitely I'll take into consideration. The IT team will inform you how to register about it and how you can go ahead with it. Excellent, Shilpa. A very claps for you that you really did 12, attempted 12 questions, and all of the questions were correct from your side. That's really appreciated. Very big claps for you. And if anyone has any confusions in the questions, they can just post it in the group if they've taken shots, or we'll try to share the PDF as well as soon as it is ready. Shall we wait for 5 minutes or should we start?
Ma'am, please start.
Yes.
We can start now.
Okay.
It's already 13 participants here.
Okay. So yeah, let's begin with our today's lecture. We have started. We have finished our maternal medicine module. Almost it is done. And now we have started our oncology module. This is the second session of our oncology module. The first one was taken by Dr. Aqsa, that is on cervical screening. And today we are going to discuss the ovarian masses, suspected ovarian masses in premenopausal, postmenopausal, neonates, and the adolescents. We are going to cover all of them together today. So just to begin with, it's a Green Top guideline number 62, management of suspected ovarian masses in premenopausal women. So from the background and the introduction up to 10% of the women will have some form of surgery during their lifetime for the presence of an ovarian mass. In premenopausal women, almost all of the ovarian mass and the cyst are benign. The overall incidence of a symptomatic ovarian cyst in a premenopausal female being malignant is approximately 1 in 1,000, increasing to 2, 3 in 1,000 at the age of 50 years. We need to understand this point, as it has been a very clear-cut SPA in Andrew Caesar, Brian. You can find it in all of the books. A very common question that the incidence of simple ovarian cyst symptomatic in the premenopausal female before the age of 50 years is 1 in 2,000, but when the woman reaches at the age of 50 years, the risk increases to 3 by 1,000 at the age of 50 years. We need to understand this point. And you also need to remember this point, as there are many frequent SBAs on this question. And among them, one of them is an exceptions, which are the germ cell tumors in which there is elevation of specific tumor markers such as alpha fetoprotein and beta HCG. And also in germ cell tumors, we need to remember that there are elevation of 3 tumor markers in case of germ cell tumor. The first one is alpha fetoprotein, the other one is the beta HCG, and the third one is the lactate dehydrogenase. However, in the guideline, only 2 of them are mentioned, but but through the strategy, we have found out that there's also elevation of the third protein tumor marker, that is lactate dehydrogenase. In 10% of the suspected ovarian masses, they are ultimately found to be non-ovarian in origin. It is important to consider the borderline ovarian tumors as a histological diagnosis when undertaking any surgery for ovarian masses, and when such a histological diagnosis is made or strongly suspected, referral to the gynae oncology unit is recommended. Whenever we are suspecting any of the tumors, irrespective whether it is endometrial, ovarian, cervical, whatever, we need to refer the patient to the gynae oncology unit. Now, in terms of preoperative diagnosis, sometimes can be difficult with radiological and serum markers being relatively insensitive, especially in their differentiation from stage 1 ovarian epithelial cancers. So although up to 20% of the borderline ovarian tumors, they appear as simple cysts on the ultrasound, the majority of such tumors will have suspicious of ultrasonographic findings. So it is very important that we understand that not only the radiology, that the images will help us. Along with the images, we need to take help from the serum markers as well, because sometimes doing one investigation may not have such a good very sensitivity and a specificity. So we need to sometimes we need to do together in combination the investigations in terms of radiological as well as the serum markers. Now, mean survival time for women with ovarian malignancy is significantly improved when managed within a specialized gynecological oncology service. Hence, early diagnosis and referral is important. For any tumor, for any malignancy, it is very important that it should be diagnosed at an early stage. And once diagnosed, it should be referred to an appropriate place. That is the gynae oncology unit. And once it has been referred, then definitely once the treatment has been started at an early stage, then the survival time increases, survival rate increases for that person, for that lady, basically. Now, what we do mean in the preoperative assessment of women. Hope I am clear to you till these slides. Am I clear? Or you want me to repeat any point for you all?
Clear.
All right, thank you. So now in terms of preoperative assessment of women with ovarian masses, what is the role of the history examination in the assessment of women with suspected ovarian masses? A doctor who's there should take a thorough medical history, should be taken from the woman with a specific attention to risk factors or protective factors for ovarian malignancy and a family history of ovarian or breast cancer. Now, history is really very important because we should know the symptoms of the malignancy also. In the history, we are going to ask the symptoms of malignancy. Like symptoms of malignancy could be any, if the patient is having any abdominal distension, increase or decrease appetite, or she's having any pain in the pelvis or the abdominal region, having pressure symptoms in the form of increased urinary urgency, frequency. And we also need to check about the weight of the woman, whether the weight has decreased, because in the malignancy, when her appetite is reduced, usually the weight is decreased. And along with that, we also need to ask from her about whether she is using any form of contraception, because some of the contraceptions, they are protective. And also we need to know about the breastfeeding status, whether she is breastfeeding her baby, or we also need to ask from the woman about the history of hysterectomy, whether her uterus has been removed or not. because these are some of the factors that we need to know from the history. And definitely, what is the importance of this family history of the ovarian or the breast cancer? We are going to discuss this in the postmenopausal um, uh, postmenopausal GTG in the next few slides. So careful physical examination of urinary, or a careful physical examination of the woman is essential and should include abdominal, the vaginal examination, and the presence or absence of local lymphadenopathy. So in the physical examination, what are we looking for? We are going to look for the general look and also the BMI of the patient. We are going to look in terms of her anemia, whether she is anemic, any element of dehydration. We need to look at these. By physical examination, we mean this. And for abdominal examination, we need to assess the mass, whether the mass is how much weeks is the size of the mass is, and if there is any associated, what is the extension of the mass, what is the features of the mass, basically we need to find out on per abdominal examination. And in the per vaginal examination, we need to assess for any tenderness, is there any nodularity or any, we can feel the bulge in the posterior fornix. We need to know these things. And along with this, we need to assess the lymph nodes also as well. Because with the lymph nodes, when we're going to discuss the malignancies, ovarian malignancy, then we need to see that the lymphadenopathy, if the lymphadenopathy is there, then the management, some of the management is also changed. We are going to discuss this in a few next lectures. So in the acute presentation of pain, in the acute presentation with pain, the diagnosis of accident to the ovarian cyst should be considered, that is torsion, rupture, or hemorrhage. If any patient who comes with an acute pain or an acute abdomen with a diagnosis that has been made as an ovarian cyst, so we need to consider the differential diagnosis as ovarian torsion. There can be torsion, the cyst can twist on itself, or there can be rupture of the cyst, or sometimes because of the rupture there can be hemorrhage of the cyst, the bleeding inside the uterus, out in the abdominal cavity. We need to see this. So we need to keep this differential diagnosis in our mind whenever a woman comes with acute abdominal pain having an ovarian cyst. We need to keep these in mind. Now, what blood test should be performed? Serum CA-125 assay does not need to be undertaken in all premenopausal women when an ultrasonographic diagnosis of a simple ovarian cyst has been made. Can anyone explain me this point, please?
CA-125 is not usually raised in benign cysts or in premenopausal age.
Okay. Yeah.
And
Yes, exactly. Very right. So if a woman who is let's take suppose a scenario, a woman is there who is 35 years old. She's and she's having we are suspecting her as a case of having a simple ovarian cyst. So how should we diagnose that cyst? If we are not doing serum CA-125, then what investigation should be done for her?
Ultrasonography.
ultrasound is more specific than CA-125.
Yes, ultrasonography. Now, what type of ultrasound? Whether it is transabdominal or transvaginal?
Vaginal.
Yes, exactly. But if the woman is not sexually active, then?
Transabdominal.
Yeah. So you need to keep this mind. There's an EMQ on this question, that there's a woman who is having a simple ovarian cyst. The first investigation in cases of premenopausal women is an ultrasonography. But when the woman is not sexually active, you have to do an ultrasound by transabdominal route. But if the woman is sexually active, you can do the ultrasound, can be done for her by transvaginal route. You need to see this buzzword very clearly, whether she is sexually active or not, because this word sexually or not sexually active can change your option. A very important point in relation to the EMQs. Am I clear this point to all of you?
Yes.
Thank you. Now, the lactate dehydrogenase, alpha-fetoprotein, HCG should be measured in all women under the age of 40 years with a complex ovarian mass because of the possibility of the germ cell tumor. So now I'll also be discussing, there was an SPA in one of the books. Most likely that I remember, it is from Andrew Caesar. There was a lady, she was having the age of 32 years. She was, when ultrasound was done for her, the ultrasound features of having a complex ovarian mass. And she was having the likely diagnosis for her was as germ cell tumor. So what are the serum tumor markers you are going to do for that lady?
Lactate dehydrogenase, alpha-fetoprotein,
And
HCG.
yes, very important that in case of germ cell tumors, we are going to do alpha-fetoprotein, beta-HCG, lactate dehydrogenase. But if there isn't any, now, if the question says the lady is same, she's having a complex ovarian mass, lady is at the age of the lady is 32 years, and she is having a diagnosis of granular cell tumor. So which tumor markers are going to be raised in her case?
Estrogen should be checked.
Along with the estrogen and
Inhibin.
Excellent. Who is this?
Dr. Chanda.
Yes, Dr. Chanda, very good, very clap for you. Excellent. You have told us a very good point that in case of granular cell tumor, there will be increase in the levels of estradiol and as well as inhibin. My third question, no worries. My third question from you is, if a patient, she has been diagnosed with a case of epithelial ovarian cancer, so which tumor marker is going to be raised?
Serum CA125.
CA125.
Yes, exactly. Excellent. Excellent, Twinkle, Sapna, all of you. Yeah, all of you are correct. Paris, thank you so much. You all are doing really very well. So I'll just repeat this point one again. In case of germ cell tumors, 3 tumor markers are going to be raised. We can remember it like 3, 2, 1. In case of germ cell, they are going to be raised in the levels of alpha-fetoprotein, beta-HCG, lactate dehydrogenase. Now, in case of granular cell tumor, there is going to be increase in the level of 2 hormones, 2 serum tumor markers, that is estradiol and inhibin. When it comes to epithelial ovarian cancer, there is going to be raised in 1, that is serum CA125. So 1, 2, 3, or you can remember it 3, 2, 1, whatever is convenient for all of you. So now CA125 is unreliable in differentiating benign from the malignant ovarian masses in premenopausal women because of the increased rate of false positive and reduced specificity. So that means CA125 is not a serum marker that is going to differentiate between benign or malignant because it has a high rate of having false positive and reduced specificity. So it's not a reliable tumor marker. However, CA125 can be raised in many frequent conditions that we are going to discuss in the next few slides. Only you just need to remember this point that it's important to note that CA125 is primarily a marker for epithelial ovarian carcinoma and it is only raised in 50% of the early stages disease. The word 50% is really very important. It is not raised in all cases of epithelial ovarian carcinoma. It is just raised in only 50% of the early stage disease. Am I clear for you? For all of you? Thank you.
Yes.
Now, when the serum CA125 assay is not necessary, when a clear ultrasonographic diagnosis of a simple ovarian cyst has been made. So when a simple ovarian cyst has been diagnosed by ultrasound, we don't need to do further investigations via doing serum CA125. If her age is less than if there's a complex ovarian mass and if her age is less than 40 years, then we are going to do 3 tumor markers, that is alpha fetoprotein, beta HCG, and LDH. But if the serum CA-125 is raised and it is less than 200 units per ml, further investigations may be appropriate to exclude and treat the common differential diagnosis. Now, in the next few slides, I'm going to tell you that what is the cutoff CA-125 that we are going to deal with. When serum CA-125 levels are raised, serial monitoring of CA-125 may be helpful as rapidly rising levels are more likely to be associated with malignancy than high levels which remain static. If the level of serum CA-125 is more than 200 units, discussion with the gynae oncologist is recommended. Guidelines from United Kingdom and the United States of America recommend that alpha fetoprotein and beta HCG should be measured in all women under 40 years with a complex ovarian mass because of the possibility of germ cell tumor. This point we have already discussed. Just to tell you the clarification of CA-125, what is the cut point that I'm going to discuss in next few slides to make it clear and easy understandable for all of you. Now, in terms of imaging, what is the role of ultrasound in the assessment of suspected ovarian masses? A pelvic ultrasound is the single most effective way of evaluating an ovarian mass, with transvaginal ultrasonography being preferable due to its increased sensitivity over transabdominal. In some cases, a combination of transvaginal and a transabdominal route may be appropriate for the assessment of larger masses and extra ovarian disease. So we already discussed this point that once we are going to do the investigation, ultrasound is the first line of investigation for women with premenopausal ovarian cysts, and ultrasound by transvaginal route will be more appropriate because of its increased sensitivity. However, other types of scan, that is color flow Doppler, 3D images, all of them, they have no role to improve the diagnostic criteria for or the diagnostic accuracy of the cyst. So only the investigation, the first investigation that we are going to do is a transvaginal ultrasonography. The use of color flow Doppler has generally not been shown to significantly improve the diagnostic accuracy, but the combined use of the transvaginal route in combination with color flow mapping and 3D imaging may improve the sensitivity, particularly in cases of complex cases. So the first line will always be ultrasound, that is transvaginal ultrasound. And then we are going to do, in cases of complex cysts, we may need to take the help by the use of color flow Doppler as well. But always the first line investigation will be transvaginal ultrasonography because of its increased sensitivity. Now, what is the best way to estimate the risk of malignancy? So an estimation of the risk of malignancy is essential in the assessment of an ovarian mass. At present, the risk of malignancy index is the most widely used model, but recent studies have shown a specific model of ultrasound parameters, the ultrasound rules derived from the International Ovarian Tumor Analysis, that is IOTA, we call it as IOTA, to have increased in sensitivity and the specificity. The routine use of CA-125 assay in the investigations of premenopausal women with an ovarian mass has not been shown to be useful because of its relatively poor specificity. So we've already discussed this point that CA-125 is not the first line investigation in case of premenopausal women. I'm repeating this point again and again because it is a very important part that you will understand when you're going to solve the EMQs with me in the next, at the end of the session, that CA-125 is not the first line investigation in cases of premenopausal women. Now, in order to assess the risk of malignancy, we can do the risk of assessment of malignancy. We have a score that we call as a risk of malignancy index, and the other one is an IOTA. Now, how do we use this risk of malignancy index? There are 4 types of risk of malignancy index. That is RMI 1, 2, 3, and 4. But till now, only RMI 1 and RMI 2 has been used validated. They have been used validatively. Now, how to diagnose, how to use this RMI score? We are going to do it now. A systemic review of diagnostic studies concluded that RMI1 was the most effective for women with suspected ovarian malignancy. The NICE guideline on ovarian cancer recommends that for women with a suspected ovarian malignancy, the RMI score should be calculated and is used to guide the woman's management. So it is the one which is going to guide us the future management. I can see from the questions. Nikita, can we have you, can you unmute yourself and please ask your question? CA 125 more than 200 or RMI?
No, 2 slides before you said we need to refer the patient to an oncologist, oncologist. If it's more than 200, it is risk malignancy index or CA 125. You said CA 125. I thought it's risk malignancy index. If it's more than 200, we'll be referring.
Yes, it is. When we are going to read when in the next few sessions, we are going to do the guidelines on NICE guideline. Then you are going to see when the CA 125 is even raised, we are referring to the patients to the gynae oncology. And when the RMI is also more than 200, we do refer the patient that we are going to discuss the flow chart. That is, there is a whole flow chart that we are going to discuss at the end of this.
Okay, thank you.
Ma'am, I have a question.
Yes,
if
please.
CA 125 is raising, then how frequently we should check that CA 125?
Excellent question. I really love your question. Definitely. I'll be answering your question in next few slides.
Okay,
Is it okay with you?
Okay.
Thank you. Yeah. So till now, the only validated score that we are using is the RMI1, that is risk of malignancy index 1, and the other one is the IOTA. Now, just one more thing to understand, that in cases of pre-malignancy, that is in premenopausal, the most widely used, although it is the RMI, but IOTA is mostly used in cases of premenopausal. However, when we talk about the postmenopausal cysts that we are going to talk, then that there comes the role of risk of malignancy index. Now, how do we calculate this RMI, that is risk of malignancy index? It is a combination of 3 pre-surgical features, that is serum CA 125, menopausal status, and the ultrasound score. So I want you to have, please all of you take a pencil and a piece of paper in your hand, because I'll be giving you some of the questions to calculate the RMI for me now, so that you can understand how to do this. Because in the exam, you have questions in which you have to calculate the RMI. So ready, all of you?
Yes, ma'am.
All right, great. So first we need to understand that how do we calculate RMI, that is the risk of malignancy index. U stands for the ultrasound score, M stands for the menopausal status, whether she is premenopausal or postmenopausal, and the value of CA 125. So now what does the ultrasound, U stands for ultrasound. So what are the features of the ultrasound? So the ultrasound score is scored as 1 point for each of the following characteristics, that is multilocular cyst, metastasis, solid areas, ascites, and bilateral lesions. If in the ultrasound, if you find all of these 5 findings, that is multilocular cyst, metastasis, ascites, bilateral lesions, and solid areas. If you find all of these, then the score will be 3. If you don't find any of the features out of this 5, then the score will be 0. If you find any one out of the 5 features, if you find only one of them is there, then the score will be 1. But if the feature is between 2 to 5, then the score will be 3. Remember, when the ultrasound features is between 2 to 5, your score for ultrasound will be 3. I'm again repeating this point. For the ultrasound features, there are 5 points we need to look for. How can we remember this 5 points? What I used to do it to remember, still I do it like this. M2 BAS. That is metastasis, multilocular cysts, bilateral lesions, ascites, and solid areas. M2 BAS, M2 SBA. You can also make it like this, M2 SBA, to just remember it. M2 means there are going to be 2 M, that is, one is for metastasis and the other one M is for the multilocular cysts. N, S stands for solid areas, B stands for bilateral lesions, A stands for ascites. If there's no feature on the ultrasound, it's going to be 0. If only one feature is there, then the score will be 1. If the features are in between 2 to 5, then your score will be 3. Am I clear till here so far?
Yes, ma'am.
Thank you. Now, coming to the M, that is the menopausal status. If the woman is premenopausal, the score will be 1. If the woman is postmenopausal, the score will be 3. Remember, if the woman is premenopausal, the score will be 1. If the woman is postmenopausal, the score will be 3. Now, how do we define postmenopausal? Postmenopausal is a woman who has no periods for more than 1 year, or a woman over the age of 50 years who had an hysterectomy done. And now, the last feature of the RMI index is the CA125. CA125 can be any value from 0 to hundreds or even thousands of units. That is, CA125 is always going to be in the units of international unit per ml. So just a question, please calculate. I'm telling you a question. You need to calculate the RMI score for a patient. There's a lady who is 45 years old. She is having severe abdominal pain, and she came into the emergency department where an emergency ultrasound was done for her, in which he found ultrasound features of ultrasound was showing a cyst of 5 into 10 centimeter, which is multilocular, which was having solid areas, and it was bilateral. And after that, a blood test was done for her that was showing an CA125 level of 15 international unit per ml. So what is going to be the RMI score for this lady?
75. Sorry, 45. 45. Sorry, 45.
Okay. So
Ma'am,
can you
she
explain me
is
how?
45. She is premenopausal, that is 1. And she is having multilocular cyst, solid areas, and it's bilateral. It's a 3, and 2 to 3 we have score for 3. And CA125 is 15. So she is having RMI of 45.
Yes, exactly. Excellent. Yes. So in the same way, in the exam also, you are going to have all the values will be given to you, and you will have to calculate the RMI score.
Dr. Aqsa, if
Yes.
CA125 is not our first line investigation, then why we added in RMI in premenopausal ladies CA125?
Look, we have this is Paris here, na? Am I right?
Yes.
This is Paris?
Yes.
Yes. Okay. Yes, Paris, exactly. Your question is very valid. Look, we have 2 ways in which we can calculate. One of them is the RMI index, the other one is the IOTA. RMI index, that is the risk of malignancy index, it is basically for the postmenopausal woman. And the IOTA is for the premenopausal women. That is why in the menopausal status, you can see it has given both the options. It can either be premenopausal or postmenopausal. Both of them is there. And CA125 is not given as the first line in the CA125 is the first line investigation in cases of postmenopausal women. This I'm going to discuss in the next GTG that we are going to discuss. That is why the RMI index is more important in cases of postmenopausal women to be calculated. Am I clear for you, Paris, so far?
Okay, doctor.
Thank you. Thank you, Sapna, Shaista, Nikita, Sonia, every one of you. All of you are correct. And you're learning expertise, becoming expertise to calculate the RMI.
2 minutes.
So, a recent systemic review showed that the pool sensitivities and specificities of an RMI score of 200 in the detection of ovarian malignancy, the sensitivity of RMI 1 is 78%, the specificity is 87%. Now, the RMI, it has a sensitivity
Ma'am, I
RMI 1.
think so you have missed a slide.
Let's check it. This one?
Yes, ma'am.
Okay. Okay, this side we have gone through it, but I'll definitely go it again for you. Which RMI should be used? That is, to date, only RMI 1 and RMI 2, they have been sufficiently validated. There are 4 types of RMI, that is 1, 2, 3, and 4. But till date, we are using RMI 1 and RMI 2. The NICE guideline on ovarian cancer recommends that for women with suspected ovarian malignancy, the RMI 1 score should be calculated and it is used to guide the woman's management. When we are going to study the guideline or NICE guideline of ovarian malignancy, then we are going to see that how RMI scores with the management, how does it comes into effective. All right.
Ma'am, in the previous slide, you told that IOTA is more sensitive and specific than RMI. And here we say that RMI is better. Is there a contradiction?
No, there's nothing said like that it's better. It says that only RMI 1 and RMI 2, they have been sufficiently validated. That means it is valid till now. It is being used. RMI score, definitely. It's one of the risk of malignancy index that we are going to calculate in all women of postmenopausal women. And IOTA, it is specifically or mostly used in cases of premenopausal women.
Okay.
Just to clear yourself, just to clear yourself, make it easier so that you don't have any confusions in your mind. Okay. Yeah, yes, please go ahead with your question. Yeah.
So for postmenopausal, it is RMI, and for premenopausal, it is IOTA. Is it like that?
Yeah. When we are going to solve the EMQs, yes. In terms of EMQs, in terms of SPA, you are going to solve it and you will find it like this. In the buzzwords, when you are going to solve it, you will find the buzzwords there. And when you're going to read it, you will just directly go to the option. And you will mark the correct option. Okay?
Okay.
So we've already learned how to calculate the RMI. So the specificity and the sensitivity of RMI 1, that is the sensitivity of RMI 1 is 78% and the specificity is 87%. Now, is there any other way to estimate accurately a risk of malignancy in premenopausal women without using CA125? So that comes from the simple ultrasound rules derived from the IOTA group. The use of specific ultrasound morphological findings without CA125 has been shown to have high sensitivity, specificity, and the likelihood ratios. If not clear, classifiable from these routes, further investigations by a specialist in gynae ultrasound is appropriate. Now, what do I mean by IOTA group? That I'm going to tell you. Now, IOTA, it is divided into B rules. By B, I mean to say benign. By M rules, I mean malignancy. Now, what are the 5 points that come in benign? That it should be a unilocular cyst, having presence of solid components where the largest solid component is less than 7 millimeter. There can be presence of acoustic shadowing, smooth, multilocular tumor with a largest diameter of less than 100 millimeter, and there will be no blood flow. I would highly appreciate if all of you can mute yourself, because it disturbs me as well, and whenever you are listening to the recording, it is difficult for everyone to understand the recordings as well. So it would be highly appreciated if you can do that for me. If you have any questions, you are most welcome. You can ask at any point of time. But when you have no any questions, I will highly appreciate if you just mute yourself. Thank you for that, everyone. So IOTA, it is divided into 2 types. That is the B. B means, by B, I mean benign. By M rules, I mean malignant. In terms of B rules, there are 5 points that we need to remember. It is going to be a unilocular cyst. It can have presence of solid components where the largest solid component will be less than 7 millimeter. There can be presence of acoustic shadowing, a smooth multilocular tumor with the largest diameter of less than 100 millimeter. There will be no blood flow in cases of B rules. Now coming to the M rules, that is the malignant rules. This will be on the ultrasound. You're going to find the features of having irregular solid tumor. There can be ascites, at least 4 papillary structures. The word at least 4 papillary structures. There's going to be irregular multilocular solid tumor with the largest diameter of 100 or more than 100 millimeter. Please remember this point. In case of B rules, it is going to be less than 100 millimeters. If it is 100 or more than 100, it is going to be M rules. And blood flow, there will be a strong blood flow. Now, when we did an ultrasound, we find that the woman is having M rules, any of the out of 5. If she is having any 1, 2, 3, 4, or 5, she will be referred to the gynae oncology service. Remember this point, irrespective of whatever the management option is going to be there, you need to choose that this patient with M rules, she will only be referred to the gynae oncology service. Am I clear? This point, please make sure you are all clear for this point.
Ma'am, I have a question. In B role, presence of acoustic shadowing, what does it mean?
When we do an ultrasound, you can see the shadows are formed. You can see the hypoequic areas, that is dull to the normal tissue, or hyperequic. That means that they're having more light than the normal tissue, surrounding normal tissue. That is what we call as acoustic shadowing. But that is not going to be our job. The ultrasound report will tell you whether there's presence of acoustic shadowing is there. In the report, it is going to be mentioned.
Okay, ma'am. Thank you.
So can you repeat the rules for me without having a look at this, the B rules?
Unilocular cyst, presence of solid component, and the size of solid component should be less than 7 millimeter if it is present, and there may be presence of acoustic shadowing and smooth multilocular tumor, the largest diameter of which is less than 100 millimeter or 10 centimeter, and there is no blood flow in color Doppler.
Excellent. Excellent. And please, if you could mind, could you repeat the M rules also for us?
Yes, ma'am. In M rules, the tumor will be solid and irregular filling. There will be ascites, and at least there must have 4 papillary structure within the tumor, And irregular multilocular solid tumor with large diameter should be more than 10 centimeter or more than 100 millimeter, and there will be more strong blood flow within the tumor tissue within the septa in Doppler, USG Doppler, color Doppler.
Yes, excellent. I'll just clear one point in the M rules. That will be irregular multilocular solid tumor with the largest diameter of 100 millimeter or more than 100. It can be 100 or 10 centimeter or more than 10 centimeter. Both can be there. 10 or more than 10, 100 or more than 100 millimeter.
Yes, ma'am. I have missed
And
it.
yeah, no problem. Just to now you'll remember it for your lifetime. You will remember it till you go into the exam hall. I'm sure you'll remember it. And when any of the M rules is found, what you will do with the patient in the terms of management?
Gynecological oncology
service. Yes, you are going to refer the patient to the gynae oncology service. Excellent.
Ma'am, do you have any mnemonics for this one?
No, dear, I just remember. Yeah, I wish I could make it one for you, but definitely because till now even I've just learned it by this way.
Okay.
Now management. Now we are coming to the management. Management of ovarian masses presumed to be benign in non-emergency situations. Can an asymptomatic woman with simple ovarian cysts be managed expectantly? Now, woman with a small woman with a small, that is less than 50 millimeter diameter or 5 centimeter simple ovarian cysts, they generally do not require follow-up. As these cysts, they are likely to be physiological and almost they resolve within 3 menstrual cycles. Women with a simple ovarian cyst of between 50 to 7 millimeter or that is 5 to 7 centimeter in diameter, they will be followed up by doing an yearly ultrasound, and those with a larger cyst that is more than 70 millimeter or 7 centimeter, they will be considered for further imaging or surgical intervention depending on the individualized patient. So I'll repeat this point once again. If we have a simple cyst which is measuring less than 50 millimeter in diameter or less than 5 centimeter in diameter, this cyst does not require any follow-up. It is likely to be a physiological one and it is going to resolve in 3 menstrual cycles. But if the simple ovarian cyst is in between 50 to 70 millimeter in diameter or 5 to 7 centimeter in diameter, we need to do the follow-up by doing a yearly ultrasound. 1 yearly ultrasound will be done for her. But if the cyst is in diameter, it is more than 70 millimeter or more than 7 centimeter, either further imaging will be done for her in the form of MRI or we need to do surgical intervention. So there are 3 points: less than 50, 50 to 70 and more than 70. Less than 50, there is no need for follow-up. 50 to 70 just once, and more than 70, you need to do certain intervention, either do treatment or imaging. Hope I'm clear to all of you this much.
Yes.
Now, how should persistent asymptomatic ovarian cysts be managed? Ovarian cysts that persist or increase in size, they're unlikely to be functional and may warrant surgical management. Now, any size which either remains same in the size or it increases, this is not going to be a functional cyst and we need to treat that cyst by doing any surgical intervention. Ovarian cysts that persist or increase in size after several cycles are unlikely to be functional Mature cystic teratomas, that is dermoid cysts, have been shown to grow over time, increasing the risk of pain and ovarian accidents. So surgical management is therefore usually appropriate with preoperative assessment using either RMI1 or ultrasound rules by IOTA group. Now, does the use of combined OCP pills help in the treatment of functional ovarian cysts? No, it does not promote the resolution of functional ovarian cyst. You need to remember this. OCPs, they have no role in resolution of the functional ovarian cyst. Okay. Now, is the laparoscope? Yes, please. Yes, please.
Ma'am, this slide. Ma'am, in this slide, the persistent asymptomatic ovarian cyst, irrespective of the size, we do treatment, or otherwise, if the cyst is less than 5 centimeter and persistent and do not resolve, then we have to give treatment.
Sorry, could you please repeat your question? There's a lot of interruption on your side. I could echo my voice. I could hear my own echo.
Sorry, ma'am. If the patient is having a cyst of less than 5 centimeter, this is persistent and patient is asymptomatic. Then do we need to treat this cyst as well surgically? Less than 5 centimeter.
Less than 5 centimeter, but it is persisting, you are saying?
Yes, persistent asymptomatic.
Asymptomatic. If it is less than 5 centimeter and it is persisting, then you don't need to do any follow-up. Why? I'm going to discuss this in the next flow chart with you.
Okay.
Okay?
Yes, ma'am.
Thank you. So now, is the laparoscopic approach better for the elective surgical management of ovarian masses? The laparoscopic approach for the elective surgical management of ovarian masses has the following benefits. But if there is a large mass with solid components like having a large dermoid cyst, then laparotomy may be needed according to the need of the patient. Now, what are the benefits of laparoscopy when we are doing a simple cyst? That is, it will reduce the morbidity, febrile morbidity, patient will have less post-operative pain, lower rates of post-operative complications, patient can be discharged earlier from the hospital, reducing the burden of the hospital, and as well as a lower overall cost for the patient as well as for the hospital as well. So we need to remember these 5 benefits of laparoscopy. In all the cases of laparoscopy, when we are going to study the laparoscopy guideline also, in this also these are the same benefits that we need to remember. That is, it will reduce the morbidity, there will be less pain, less complications, less post-operative complications. Patient can be discharged earlier from the hospital, and it is cost effective for the patient as well as for the hospital as well. So just 5 benefits: less febrile morbidity, less pain in the post-operative period, less complications in the post-operative period, early discharge from the hospital, and less of a cost effective. It is more cost effective. Now, who should perform the laparoscopic surgery for a presumed benign ovarian cyst? So it will be performed, the laparoscopic management of a presumed benign ovarian cyst. It should be undertaken by a surgeon with suitable experience and appropriate equipment whenever local facilities permit. Now, the surgical management of ovarian masses, it depends on the several factors. That is the woman, including what is the suitability for her laparoscopy and what is the wish of the woman. That also needs to be respected. Now, in terms of the mass, that is the ovarian cyst, what is the size of this cyst, whether it is simple or complex, and what is the nature of the cyst, whether it is benign or malignant, and the setting that where she has come, whether it includes the surgeon skills are there, the equipment are present there to go for the laparoscopic surgery, because it's a very delicate surgery. So we need to consider 3 factors. One is for the woman, the other is for the mass, and the third one is for the setting, that is the place where we are working. We need to consider all 3 factors when dealing with the surgical management. Now, a decision should be made after careful clinical assessment and counseling considering the above factors. Should an ovarian cyst be aspirated? Aspiration of ovarian cyst, either vaginally or laparoscopic, it is less effective and it is associated with a high rate of recurrence. So never should be a cyst ovarian should be aspirated because it has a very high recurrence rate, that is from 53% to 84%. So never we should aspirate a cyst, ovarian cyst, because the recurrence rate is high, that is from 53% to 84%. That is why we should never ever aspirate an ovarian cyst. Now, is it important to avoid an unplanned rupture of the cyst? Yes, definitely it is an important. Why? The spillage of the cyst contents should be avoided where possible, because as preoperative and intraoperative assessment cannot absolutely preclude the malignancy. Consideration should be given to the use of a tissue bag to avoid peritoneal spills of the cystic content, bearing in mind that the likely preoperative diagnosis. It is preferable to avoid spillage of the cyst contents because the apparently looking benign cyst characteristics of a cyst on preoperative and intraoperative assessment cannot absolutely preclude malignancy. And if a dermoid cyst gets spill out, there is a chance of having a chemical peritonitis that happens in around less than 0.2% of the cases. Ideally, we should not, ideally the spillage should be avoided, because if we are doing the ultrasound or any investigations, we find that the cyst is benign. But intraoperatively, we found out that the cyst comes out to be malignant. That is why the content of the cyst should not be spilled in the cavity. Because if it is going to be spilled in cases of dermoid cyst, there's a risk of having chemical peritonitis that is less than 0.2%. But if accidentally there occurs the spillage, now what to do? If an inadvertent spillage does occur, there could be meticulous peritoneal lavage of the peritoneal cavity. It should be performed using large amount of warm fluid. Now remember the word, the warm fluid should be used. Now the use of cold irrigation fluid may not only cause hypothermia, but will also make contents more challenging by solidifying the fat-rich contents. Any solid content should be removed by using an appropriate bag. So we should remember that if any spillage occurs, we need to lavage the peritoneal cavity by using large amount of warm fluid. Why not the cold fluid? Because it will cause hypothermia, and also it will make the fat content of the content, it will solidify it. So it will be very difficult to remove from the peritoneal cavity. If any solid content, it should be removed using an appropriate bag. Now, when should an oophorectomy be performed? The possibility of removing an ovary should be discussed with the woman preoperatively. The pros and cons of electively removing an ovary should be discussed, taking into consideration the woman's preference and the specific clinical scenario. Because removing an ovary has its own hazards, has its own benefit as well. So we need to discuss both with the patient, and according to her wish, that will be done. Now, in terms of benefit, what is going to be the benefit? That when we remove the ovary, definitely she will land up in having a surgical menopause. And once she land up into surgical menopause, she can have bone problems, problems with the heart, all the menopausal symptoms like mood swings, hot flushes, night sweats, all will be there. So for that, again, we'll have to start on the treatment of hormonal replacement therapy. That is when another story begins from there. But if we remove the ovary, yes, there will be decrease in the risk of ovarian cancer. But in all the population, there is a generalized risk of ovarian cancer. Definitely, this will be discussed in the NICE guideline. I'm not going to discuss this point now. Now, how should an ovarian mass be removed? Where possible, the removal of benign ovarian mass should be via the umbilical port. Please remember this point. The umbilical port is the point in the laparoscopy that the cyst should be removed. Why? Because it will cause less post-operative pain and a quick retrieval time than when using the lateral ports of the same size. And along with that, avoidance of extending accessory ports is beneficial in reducing pain, reducing the incidence of incisional hernia, and the incidence of epigastric vessel injury. It also leads to improved cosmesis. So you need to remember this point, that whenever the laparoscopy will be done, the port will only, that is the good port or the benefited port, the port that has more advantage is going to be the umbilical port. Why not the any other port? Because it can cause incisional hernia, it can cause damage to the epigastric vessels, which can lead to severe hemorrhage. So you need to remember this point. Whenever there's going to be injury to the secondary port, the vessel which can be damaged is the epigastric vessel. Remember my words, whenever in the secondary port there is going to be any injury, the damage to the nerve, damage to the vessel that is going to be damaged is the epigastric vessel. This is a very important SBA in case of secondary port. The vessel that is damaged is the epigastric vessel, and the port that is used is the umbilical port. Am I clear so far?
Yes.
Yes,
Thank
ma'am.
you. Okay. Yeah. So we have completed this. Yeah, we have completed this premenopausal guideline. I'll just quickly revise few of the points which are very important. So first of all, the premenopausal cysts, they are very common, and usually most of them, they are benign. The chances of being the premenopausal ovarian cyst to be turn into malignancy is 1 in 2000, but at the age of 50 years, the risk becomes 3 in 1000. Remember this point, from 1 to it becomes 3 in 1000 at the age of 50 years. There's a clear-cut BCQ from Andrew Caesar on this. You cannot leave any marks on just simple questions, these simple questions. There's no excuse for all these simple questions at least. Now, we have, in terms of, if we have germ cell tumor, then the tumor markers that are going to be raised is going to be alpha fetoprotein, beta HCG, and the third one is going to be LDH. If it's going to be a granular cell tumor, there will be increase in 2 tumor markers, that is estradiol and inhibin. In case of epithelial ovarian cancer, there will be raised in 1 tumor marker, that is CA125. 3, 2, 1. Now, we need to, whenever a woman comes with a premenopausal cyst, we need to take the history, and after taking the history, we are going to do the investigation. The first line investigation that we are going to do in case of premenopausal ovarian cyst is the ultrasound by transvaginal route, is the first line of investigation that is need to be done. Along with that, supportive can be done like in the form of transabdominal, but the first line investigation will always be transvaginal ultrasound. We have 2 scores. We have 2 ways to calculate the the malignancy, the risk of malignancy. That is, one is the risk of malignancy index, which has 3 features. That is ultrasound features, menopausal status, and CA125. The other one, we have the IOTA group, which has ultrasound features, B rules, and the M rules. Now, whenever the cyst is found, we need to manage the cyst according to the size. If the simple ovarian cyst is measuring less than 50 millimeter in diameter or less than 5 centimeter in diameter, this cyst needs only no follow-up. This cyst needs no follow-up. Remember my words, no follow-up. But if the cyst is measuring 5 to 7 centimeter in size, the follow-up will be 1 yearly by doing an ultrasound. If the size of the cyst is more than 7 centimeter, we need to do certain intervention, either in the form of surgery or in the form of investigations. Any one has to be done for the patient. Another one point that was really very important, that OCPs does not cause the resolution of the functional ovarian cyst. In terms of laparoscopy, for the removal of the ovarian cyst, laparoscopy is the best approach. In laparoscopy, the surgery should be done by the umbilical port because it is very effective. It will cause less post-operative pain quicker. The surgery will be done quicker and less incidence of having incisional hernia, and there will be no injury to the epigastric vessels. And why the laparoscopic approach is better? Because it will reduce post-operative morbidity, early recovery for the patient, cost-effective for the patient, and earlier discharge from the hospital. But however, if the cyst is large with solid components or it is a complex cyst, then laparotomy may be needed. Am I clear for all of you so far?
Yes.
Shall we move to the next guideline?
Yes, please.
Yes, ma'am.
Thank you. So the next. Yeah, the next one is that we're having the management of ovarian cysts in cases of postmenopausal women. It's a Green Top guideline number 32, which was published in July 2016.
Ma'am, can I just ask one doubt, please?
Yes, sure.
Ma'am, when you said that TVS is the first choice of investigation for any premenopausal cyst, so do we do it with Doppler or not? Because I got confused, because in IOTA we are seeing the vascularity, like whether the color blood flow is strong or not there. So we need to do it with Doppler, right?
No. Remember this point, a simple ultrasound, transvaginal ultrasound is the first line investigation. In addition, you can do Doppler, you can do MRI or CT scan. Additional can be there, but the first line will always be transvaginal ultrasound.
Okay, ma'am. Okay. Thank you.
Thank you. Yes. So in terms of the diagnosis and the significance of ovarian cysts in postmenopausal women, clinicians should be aware of the different presentations and the significance of ovarian cysts in postmenopausal women. In postmenopausal women presenting with acute abdominal pain, the diagnosis of ovarian cyst accident could be considered that is torsion, rupture, or hemorrhage. That is the same point in case of either premenopausal or in case of postmenopausal. When there's acute abdominal pain with an ovarian cyst, either that cyst can twist on itself, that is torsion, it can rupture, it can cause bleeding. So in cases of when it happens in cases of postmenopausal women, if any woman presents with a postmenopausal woman, you need to refer to that patient for immediate evaluation. Remember this point. Whenever there's a postmenopausal ovarian cyst, and she is having any complaint with that, and it's a significant size, if the cyst is going to be less than 1 centimeter in size, postmenopausal cyst less than 1 centimeter in size, there's no need for further follow-up. But if the cyst is 1 centimeter or more than 1 centimeter, it requires immediate evaluation. Remember this difference. In case when it's requiring immediate evaluation in cases of postmenopausal cysts, if it is 1 or more than 1 centimeter. But in cases of premenopausal, it was
5.
When do we need to?
Less than
5. 5. Less than 5, no follow-up. Remember?
5 to 7. Yes.
5 to 7, yes. 5 to 7. 5 to 7 centimeter, we are going to do the follow-up. Remember, I'm going to
yearly.
discuss this in variations with the premenopausal in comparison with it, so that you remember the differences. Whenever you read the guideline next time, or whenever you go through this presentation again, you just can make out these differences. And once you are able to do it, I've made my day for that. So it is recommended that ovarian cyst in postmenopausal women should initially be assessed by measuring CA-125 level and transvaginal ultrasound. Remember this again, a very big difference is there. In case of premenopausal women, if a cyst is there, the first line investigation is transvaginal ultrasound. But in case of postmenopausal women, the first line investigation is CA-125. Remember, along with CA-125, you are going to do the transvaginal ultrasound, but not the first line investigation. Am I clear to all of you this point?
Yes.
It should be in your fingertips now. There should be no any confusion with this point, because the guideline, it clearly mentions in case of premenopausal women, the first line investigation should be
Premenopausal, it's
TVS.
TVS.
First line is TVS and
TVS.
postmenopausal first line is CA-125.
CA-125 and TVS.
And
TVS.
TVS.
Yes. Remember this difference. Remember a very big difference. You are going to solve the questions by yourself in the EMQs, especially in the EMQs. I'm more concerned with the EMQs. SPA is also very important. Yes, SBs, no doubt they are not important, but EMQ, when there are 10, 15 options and you look at them, you all get confused. So you need to remember the buzzword, postmenopausal woman. In the postmenopausal woman, the first line investigation will always be CA-125 along with TVS. Any of the other options are given, all are wrong. Believe me, all the options are wrong. The only option you will mark, close your eyes and mark it CA-125 and TVS as the first line investigation. In case of premenopausal, the first line investigation will be transvaginal ultrasound. Now, what is the role of history and clinical examination in postmenopausal women with ovarian cysts? A thorough medical history should be taken from the woman with specific attention to the risk factors and the symptoms suggestive of ovarian malignancy, and a family history of ovarian, bowel, or breast cancer. Now, this is also exactly the same point, that medical history, we are going to ask about the symptoms of malignancy from all the patients, and also any risk factor, whatever is present, and also the family history. Now, family history is very important in cases of postmenopausal ovarian cyst. By postmenopausal, I mean in terms of ovarian cancer, bowel cancer, or breast cancer. Now what does I mean by family history? I'll tell you in the next slide. But whenever the family history is positive in case of postmenopausal ovarian cyst, you need to refer the patient to the regional cancer genetics service. With the family history is positive, referral to the regional cancer genetics service should be considered. Why genetic service? Can anyone tell me?
10% are
for breast cancer and HN.
Yes.
Lynch syndrome.
Yes, Lynch syndrome, BRCA genes. We are looking for the BRCA genes.
Yes, CA1 and
yeah,
2.
That is a complete talk article, a different talk article. We will be discussing that, not today, but in the next sessions, we can discuss some other day. But the point is that whenever family history is positive, please, I'll appreciate if you all mute yourself just on the point. If you want to ask questions or you have any queries, I'll highly appreciate for you. So whenever the family history is going to be positive, we are going to refer the patient to the regional cancer genetic service. Now, what do I mean by the family history? I'm going to tell you. Appropriate tests should be carried out in any postmenopausal woman who has developed symptoms within the last 12 months that suggest of irritable bowel syndrome, particularly in women over 50 years of age or those with a significant family history of ovarian, bowel, or breast cancer. Within last 12 months, if the woman is having any symptoms along with a positive family history, we need to evaluate that patient by doing CA125 and transvaginal ultrasound as the first line investigation. And by physical examination, I mean to say it is essential and it should include the BMI, the body mass index, abdominal examination, to see the features of the mass, what is the consistency of mass, what is the nature of the mass, and also to look for ascites and any characteristics of the palpable mass. Along with that, a vaginal examination. Although clinical examination has poor sensitivity in the detection of ovarian mass, now how much poor sensitivity? It is 15 to 51%. Remember this, 15 to 51%. There's an SP on this. Whenever you find in my slides, there's written SPA or EMQ. This is an EMQ or SP either from the recall or any of the books. You must highlight these points in your, wherever you are reading, or just keep it in your mind that these are from the references books or from the strategy or from the recalls taken from there only, not from anywhere else. So the clinical examination, it has a poor sensitivity in the detection of ovarian mass by how much? 15 to 51%. Now, by what do I mean by family history? Family history can be used to define women who are at increased risk of ovarian cancer. A woman is defined as being at high risk of ovarian cancer if she has first degree relative. By first degree relative, I mean the mother, the father, brother, sister, daughter, or her son. They are affected by cancer within a family with, now to remember, if it is a one individual, if one person is affected with ovarian cancer at any age and one with breast cancer under the age of 50 years, who are first degree relatives of each other. One individual will be with ovarian cancer, the other one will be with the breast cancer under the age of 50 years, and they are going to be the first degree relative. By first degree relative, I mean she can be the mother, father, brother, sister, daughter, or a son. Now, coming to two or more individuals, two or more can be with ovarian cancer who are first degree relative to each other. And if there's only one relative with ovarian cancer at any age and two with breast cancer under the age of 60 years who are connected by first degree relationships. And if there are three or more family members with colon cancer, or two with colon cancer and the other one is with stomach, ovarian, endometrial, urinary tract, or small bowel cancer in 2 generations, and it should be under the age of 50 years, and their affected relatives should be the first degree relative with each other. So all will be the first degree relative in cases of family history. You need to remember this point. And the other one, the one individual with either she's the same person who's having the breast and the ovarian cancer at the same time. I'm going to repeat this family history again. By family history, I mean to say that it can be in terms of first degree relative. She can be a mother, a father, sister, brother, son, or a daughter. If one individual is affected with ovarian cancer and the other one with a breast cancer, the age will be less than 50 years of age, and they will all be first degree relative to each other. If 2 or more individuals are affected with ovarian cancer, but they should also be first degree relative to each other. If one relative is with ovarian cancer and the other one is with breast cancer, but the age should be under 60 years of age, and they all should be first degree relative to each other. If there are 3 or more family members, one with colon cancer or the other one with colon, and can have stomach, ovarian, endometrial, urinary tract, or small bowel cancer, but the age should be less than 50 years. And if there's only one person, the person can have either the breast and the ovarian cancer. Am I clear? This slide is
too difficult.
Yeah.
Madam,
Yes,
how to memorize these?
Sorry for the interruption. Yes, you don't need to like memorize it or mug it up. You need to remember that they're all going to be the first degree relative. Either they can have ovarian cancer, they can have breast cancer, or endometrial cancer. They can have colon cancer, urinary tract cancer. And the same person can have both, that is the breast and the ovarian cancer. And either the age is going to be less than 50 years or age is going to be less than 60 years. Because you need, in the questions, you're going to just find that this is a first degree relative who is having ovarian cancer or is having a breast cancer. In the questions, you will find just like this. You don't need to like memorize these points. Just make
Excuse
your
me, ma'am.
concept. Yes, please.
Ma'am, would you happen to have questions with regards to this family history, so that that would make it easier for us to memorize this?
Yeah, sure.
If you would post questions for this.
Yeah, I have made few questions for today's session, but tomorrow or by night today, I can post more questions in the group, specifically
Okay, that'd be
related to
great.
family history. Yeah, thank you. Whenever the family history is going to be positive, you are going to refer. Whenever the family history is going to be positive, you are going to refer that patient to the genetist. The first line, the first management option for you will be referring that patient to the genetist. Remember this EMQ. Whenever any family history in the first degree relative is positive, you need to refer that patient to the genetist. Remember my words, refer to the genetist. Now, what blood test should be performed in postmenopausal women with ovarian cysts? That is the same that we have already discussed, that CA-125 should be the only serum tumor marker used for primary evaluation, as it allows the risk of malignancy index for ovarian cysts in postmenopausal women to be calculated. A normal value does not exclude ovarian cancer due to the non-specific nature of the test. Now, the use of serum CA-125 is well established. It is being raised in over 80% of the epithelial ovarian cancer, but not in most of the mucinous ovarian cancer. Remember this point, that CA-125 is a tumor marker for epithelial ovarian cancer. However, it only diagnosed 50% of the cases. If a cutoff of 30 international unit per ml is used, the test has a sensitivity of 81% and a specificity of 75%. Remember this line, if the test is used as a value, if the cutoff value for CA-125 is taken as 30 international unit per ml, it has a sensitivity of 81% and a specificity of 75%. It's a clear-cut MCQ of, I think, from the Brian. When you're going to solve it, just post it in the group and we'll do it together. That if the cutoff is 30, it has a sensitivity of 81% and a specificity of 75%. There's nothing in this, just you need to mug up this line.
Ma'am, sorry to interrupt you. Previously, we saw some sensitivity of 87% and specificity of 78%. I just forgot what it was.
That was for a risk of malignancy index.
RMI, isn't it? Oh, okay. Okay, thank you.
Thank you. Now, who is this with us? Who was this?
Yeah, I was Sapna.
Sapna, can you do me a favor, please?
Yes, ma'am.
Yes. Can you repeat the RMI? How do we calculate the RMI?
RMI is calculated as the product of U into M into CA125. U is the ultrasound score, 0, 1, and 3. 0 if there are no features, 1 if there is one feature, and 3 if there are 2 to 5 features. The features being metastasis, multilocularity, solid areas, ascites, and bilaterality. And menopausal status, 1 for premenopausal, 3 for postmenopausal. And CA125, the absolute value.
Exactly. Excellent. Very good. Yeah. Yes. So I'll not. Yeah. So this is the same point that RMI has to be calculated this way, like that Sapna has told us right now. Now, in terms of RMI, you need to remember one thing, that RMI, it is an index of risk of malignancy index. When the score of the RMI is less than 25, the risk of malignancy is also less than 3%. And if the RMI score is in between 25 to 250, the risk of malignancy is 20%. If the score of the RMI is more than 250, the risk of malignancy index also rises by 75%. I'm going to repeat this point once again. If the RMI score is less than 25, the risk of malignancy is less than 3%. Remember, these three are the SPAs from Andrew Sizer. When the RMI score is less than 25, the risk of malignancy index is less than 3%. If the RMI score is in between 25 to 250, the risk of malignancy is 20%. If the RMI is more than 250, the risk of malignancy is 75%. Am I clear?
Yes, ma'am.
Thank you.
Excuse me, ma'am, sorry to disturb you. The RMI and the risk of malignancy the values that you've just told, do they correspond to premenopausal women as well as postmenopausal women?
Yes. It corresponds to both of them. Either it is premenopausal or postmenopausal women.
Okay, and the last point was that if it's more than 250, the risk of malignancy would be 70%, right?
75.
75. Thank you, ma'am.
You're welcome. Okay, now when we do CA125, what are the conditions in which CA125 can be raised and what are the conditions in CA125 can be decreased? So there are three conditions in which CA125 decreases. Remember these three: smoking, caffeine intake, and hysterectomy. In these three cases, the CA125 level of CA125 decreases. There is an SPA on this point. CA125 can be decreased in three conditions: smoking, caffeine intake, and the other one is the hysterectomy. Only 3 points. However, CA125 can be raised in several conditions like PID, fibroids, endometriosis, or there's an acute even in the benign cyst, that is in cases of torsion or hemorrhage. Then can be non-gynecological conditions, that is TB, cirrhosis, ascites, hepatitis, pancreatitis, peritonitis, and pleuritis. Or in cases of some primary tumors that can metastasize to the peritoneum, that is the breast, pancreas, lung, and colon cancer. You need to remember the very important point that CA125 is decreased in three conditions: smoking, caffeine intake, and third one is, and the last is the hysterectomy. Now, what are the other tumor markers that can be used? There is currently not enough evidence to support the routine clinical use of other tumor markers. Except for CA125, we don't use any other tumor marker like human epidermis protein, carcinoembryonic antigen, alpha-fetoprotein, lactate dehydrogenase, or beta-HCG to assess the risk of malignancy in postmenopausal ovarian cyst. Remember the word postmenopausal ovarian cyst, because in cases of premenopausal, we do alpha-fetoprotein, lactate dehydrogenase, and beta-HCG to diagnose germ cell tumor in a woman of less than 40 years. You need to remember in cases of postmenopausal women, the only tumor marker that can be done is CA125. Now, what imaging should be employed in the assessment of ovarian cysts in postmenopausal women? That is, the transvaginal pelvic ultrasound is the single most effective way of evaluating ovarian cysts in postmenopausal women, along with CA125 that we all know. Now, transabdominal ultrasound should not be used in isolation. It should be used to provide supplementary information to transvaginal ultrasound, particularly when the ovarian cyst is large or beyond the field of the transvaginal ultrasound. So transabdominal can be used as a supportive. It should not be used as a first line investigation. Now on transvaginal scanning, the morphological description and the subjective assessment of the ultrasound features should be clearly documented to allow the calculation of the risk of malignancy. Transvaginal ultrasound scans should be performed using multi-frequency probes by trained clinicians with expertise in gynecological imaging. Now, Paris, this is your homework. You are going to tell me that which tumor marker is raised in cases of mucinous ovarian tumor. There's a talk article on it. I want you to go through it and please let me know. Tomorrow I'm going to see the Telegram group for your answer.
See.
Now, how to differentiate that whether it is a simple cyst or a complex cyst? We have certain features. In cases of simple cysts, the cyst can be either round or oval shaped. It will be thin or imperceptible wall. There can be posterior acoustic enhancement, anechoic fluid, or there will be absence of septations or no nodules. But in cases of complex cysts, there will be septations, that it can be multilocular cysts, there will be solid nodules and papillary projections. So these are the differentiating points between the simple and the complex cyst. In case of simple, we have 5 points, and in case of complex, we have 3 points. So 3 for CA125 and 3 for complex cyst, 3, both. Easy to remember, 3 for CA125 and 3 for complex ovarian cyst. For CA125 is decreased in cases of caffeine intake, smoking, and hysterectomy, 3 points. For complex, again 3 points, that is complete septations, multilocular, solid nodules, and papillary projections. And we need to remember these features because they are going to help us in solving our SPS and EMQ. Clear so far?
Yes, ma'am.
Okay. Now, what is the role of the Doppler and three-dimensional ultrasound studies? Color flow Doppler studies are not essential for the routine initial assessment of ovarian cyst in postmenopausal women. So remember, in either in premenopausal and in postmenopausal women, they are not essential for the routine initial assessment. However, they can be used in spectral, and pulse Doppler indices should not be used routinely, like resistive index, pulsatile index, peak systolic velocity, time average, to differentiate between benign from malignant, as their use has not been associated with significant improvement in diagnostic accuracy over morphological assessment by ultrasound. So color for Doppler is not the first line, is not the routine investigation to be done. Neither is the CT scan, MRI, or positron emission tomography. None of them is used as the first line of evaluation in cases of postmenopausal women. None of them is used. Remember, only CA125 and TVS is used as a first line investigation. So three-dimensional ultrasound morphological assessment does not appears to improve the diagnosis of complex ovarian cyst, and its routine use is not recommended. It is not recommended in the assessment of postmenopausal ovarian cysts. CT scan, MRI, positron emission tomography scans are not recommended. The word "not" is very important here to remember. They are not recommended for the initial evaluation of ovarian cyst in postmenopausal women. Only the first line investigation will be CA125 and transvaginal ultrasound. All others can be the additional investigation, but never will be the first line investigation. Now, if from the clinical picture, ultrasound findings and tumor markers, a malignant disease is suspected, then you can go ahead with the CT scan of the abdomen and pelvis should be arranged with referral to the gynae oncology multidisciplinary team. Whenever a malignancy is going to be suspected, we are going to arrange for a CT scan of the abdomen and pelvis and refer that patient to the gynae oncology multidisciplinary team. Because now their domain comes, they will come into action and they will take care of the pain management of the patient. MRI should not be used routinely as the primary imaging tool for initial assessment of ovarian cysts in postmenopausal women. MRI should be used as a second-line imaging modality for characteristics of indeterminate ovarian cysts when ultrasound is inconclusive. So remember this point, the second-line investigation in cases of postmenopausal ovarian cyst will be MRI when the ultrasound is inconclusive. Otherwise, the first line investigation will always be CA125 and transvaginal ultrasound. And the second line will be MRI if needed. Now, initial assessment and estimation of risk of malignancy index. The RMI is the most widely used, available, and the validated effective triaging system for women with suspected ovarian cancer. RMI, if the RMI score is less than 200, it has a sensitivity of 78% and a specificity of 87%. But remember, when the RMI score becomes 250, the sensitivity it decreases by 70%. However, the specificity increases from 87 to 90%. Please make sure you clear this point in your mind that when the RMI score is 200, the specificity is 87. When the score increases to 250, the specificity it increases by 90% and the sensitivity it decreases. Now, what is the cutoff value that we are going to take in our patients according to the guideline? That is, the value of 200 is the cutoff value. Remember this point, 200 is the cutoff value that we are going to take from the guideline as the source when we are going to treat our patients. What is now CT scan of the abdomen and pelvis should be performed for all postmenopausal women with ovarian cyst who have an RMI score greater than or equal to 200 with onward referral to gynae oncology multidisciplinary team. Someone was asking me that what is the cut of the CA125 RMI score. So we are going to take the cutoff value as 200. Remember this point, the cutoff value. In some of the other strategies or the other book, you may find the value as 250. But take the reference from the guideline, green top guideline, that we are going to take the value as 200. Mark my words, 200 is the cutoff value. Don't deviate any other way else. Whatever is the reference, your main reference is only the green top guideline.
Excuse me, ma'am.
Yes.
Ma'am, by the cutoff value, you mean for referral to gynae oncology, right?
Yes, the gynae oncology and the further management plan.
Okay. Thank you.
Now, in terms of management, we are going to talk about if the cyst is asymptomatic, is simple, unilateral unilocular ovarian cyst, and is less than 5 centimeter in diameter. Remember, less than 5 centimeter in diameter. It has a low risk of malignancy. In the presence of normal CA125, these cysts can be managed as conservatively with a repeat evaluation in 4 to 6 months. Remember, if the postmenopausal ovarian cyst is less than 1 centimeter, there is no need for follow-up. If the cyst is 1 centimeter or more than 1 centimeter, we need to do now interventions or we need to do any imaging. Something has to be done from 1 centimeter. So you need to understand this point. If the cyst is asymptomatic, it is simple, unilateral, unilocular, less than 5 centimeter, and has a low risk of malignancy with CA125 normal value. Kindly manage the cyst as conservatively by doing a repeat evaluation in 4 to 6 months. Now, what do I mean by repeat evaluation? The word repeat evaluation, it means to do
repeat ultrasound
and
CA125.
CA125.
Yes.
CA125.
In a period of 4 to 6 months.
Okay.
Clear? It is reasonable
Yes.
to discharge these women from follow-up after 1 year if the cyst remains unchanged or it reduces in size with normal CA125, taking into consideration the woman's wishes and the surgical fitness. Then, after 1 year, the patient can be discharged from the follow-up if her CA125 is normal and along with that, the size of the cyst reduces or it becomes unchanged in size. Then we can discharge this patient after 1 year. But if the woman is symptomatic, further surgical evaluation is necessary. Remember the difference between asymptomatic and symptomatic. If symptomatic, you need to do surgical evaluation, either by laparoscopy or laparotomy, depending on the cyst. You will do it, but you will have to go for the surgical evaluation. But if it is asymptomatic, having all these features, simple, unilateral, unilocular, less than 5 centimeter with a normal CA125, repeat evaluation in 4 to 6 months. A woman with a suspicious or persistent complex adnexal mass needs surgical evaluation. Now, in case of aspiration is not recommended either in cases of premenopausal, not in cases of postmenopausal, because it has a very high rate of recurrence. For the management of variances in postmenopausal women, except for the purpose of, just give me a second, please. Yes, sorry for the interruption. Aspiration is not recommended either in cases of premenopausal, not in cases of postmenopausal, except for the purpose of symptom controls in women with advanced malignancy who are unfit to undergo surgery, or when there is any further intervention needed. Then there's only an exceptional case that you need to remember. That is when there's an advanced malignancy in which the woman is unfit for the surgery, or there's need to be further investigation, intervention that we needed. Otherwise, we do not aspirate the cyst because it has a very high risk of having a recurrence rate. Can anyone tell me, repeat the recurrence rate for having the high recurrence? What is the recurrence rate?
0.2.
No, that was the recurrence rate of
15 to
53 to 84%.
Yes.
15 to 51%.
Yes.
15 to 51%.
What?
53 to
Sorry,
84.
53 to 84. Yes, yes. 53 to 84. That's the right answer. Recurrence rate is as high as 53 to 84%. And when someone who was asking for, who said 0.2%, that is the incidence of chemical peritonitis.
Oh, sorry, ma'am. I completely forgot.
51%.
Please repeat this. Please repeat this percentage.
Yes, I'll repeat it. Normally, we do not aspirate the cyst, either in cases of premenopausal or postmenopausal women, because it has a very high recurrence rate. What is that high recurrence rate? From 53 to 84%.
Okay. Thank you.
Okay, you're welcome, dear. Only we aspirate the cyst in case of postmenopausal women when she's unfit for the surgery or she needs further investigations. These are the only two indications. Now, you need to understand this point that women with the RMI score of less than 200, that is low risk of malignancy, they are suitable for the laparoscopic management. Whenever you get a question in which the RMI score is less than 200, your management will be laparoscopic, always. Remember this buzzword of less than 200 RMI score, your management will be laparoscopic. Now, laparoscopic management for ovarian cysts in postmenopausal women should be undertaken by a surgeon with suitable experience. Laparoscopic management of ovarian cysts in postmenopausal women should comprise of bilateral salpingo-oophorectomy rather than cystectomy. So we are going to do bilateral BSO rather than only removing the cysts in cases of postmenopausal women, because we don't have any concerns with the function of the ovary at that time, at that age after the menopause. That is the reason for it. Now, we also need to explain the women that women who are going a laparoscopic salpingo-oophorectomy should be counseled pre-operatively that a full staging laparotomy will be required if there any malignancy is revealed during the intraoperative session. Now, we need to remember this point. I'll repeat it again. Women who is undergoing laparoscopic salpingo-oophorectomy, they should be counseled that a full staging laparotomy will be required if there is any evidence of malignancy. Now, where evidence, The spillage should be avoided. Why spillage should be avoided? Because it will reduce the less post-operative pain. We'll be having a quicker surgery. We don't know whether it is a benign or a malignant cyst. That is why we need to avoid the spillage. And the best port in the laparoscopy will the umbilical port, because it will cause less post-operative pain, quick recovery. It will avoid the incisional hernia. It will avoid injury to epigastric vessels. The same point, I'm repeating it. Clear so far?
Yes.
Thank you. But you need to remember, if the RMI score is less than 200, laparoscopic management. If the RMI score in a postmenopausal woman is greater than or equal to 200, CT scan findings, clinical assessment, or findings at laparoscopy, this patient requires a full laparotomy and a staging procedure. Remember this point. If the patient is having RMI score of less than 200, your first management will be laparoscopy. If RMI is 200 or more than 200, your management will be laparotomy and staging, full laparotomy and staging. Now, if a malignancy is revealed during laparoscopy or from subsequent histology, it is recommended that the woman will be referred to cancer center for further management. Now, remember also this point that when the RMI score is more than 200, you will refer the patient to the cancer center. But if the RMI score is less than 200, you will refer the patient to the general gynae unit. Remember these 2 to 3 differences between RMI. If the RMI score is less than 200, you will do the laparoscopic as the management choice, and you will refer the patient to the general gynecological service. But if the RMI score is 200 or more than 200, you will do full staging laparotomy, and you will do full laparotomy and staging. Along with that, you will refer the patient to the cancer center, because she will be dealt by the trained gynae oncologist. But if the RMI score is less than 200, the patient will be managed at the general gynae by the general gynecologist. Remember these 3 points. I'm repeating it once again. If the RMI score is less than 200, your management will be laparoscopy. You will refer the patient to the sorry. I'm going to repeat it. If the RMI score is less than 200, you will refer the patient. The first line management will be laparoscopy. You will refer the patient to the general gynecological service, and patient will be dealt by the general gynecologist. If the RMI score is 200 or more than 200, the patient will be having full staging laparotomy. Along with that, she will refer to the cancer center, where she will be treated by the trained gynecologist. Oncologist will be the person who will be treating it. In cases of less than 200, it will be the general gynecologist. In cases of more than 200, it will be the oncologist. Remember these differences. Please mark my words, write down somewhere, write down in your under your guideline or in a notebook, that you don't forget these points. In the end, you don't have the time to revise the whole guideline. Just revise these small points that will really help you out.
Excuse me, ma'am, would you please repeat it? If the RMI is less than 200, we'd refer the patient to the general surgeon?
General gynae.
General gynae, okay. Okay, thank you.
Now, we are going to study this algorithm. This is from the guideline. You need to see that if it's a postmenopausal, yes, it's a postmenopausal ovarian cyst. If the cyst is less than 1 centimeter, don't do anything. Just no even follow-up. If the cyst is 1 centimeter or 1 or more, your first line investigation will be CA 125. Along with that, TVS plus minus, you can do TAS. Remember, in cases of postmenopausal women. And then you are going to calculate the RMI score because you have the value of CA 125, you have the features of the ultrasound, and you know the age of the lady. Because she's postmenopausal, the score will always be 3M. So you can calculate the RMI. Now, once you have calculated the RMI, if RMI, the always value that we are going to take is less than 200, to the value cutoff value is 200. If it is less than 200, your patient is a low risk of malignancy. Now, you need to see the features of the cyst that we discussed, the 5 features. It's asymptomatic, simple, less than 5 centimeter, unilocular, unilateral. Go for the conservative management. Do not do anything. Conservative management in 4 to 6 months. But if the cyst is there with any of the following features, that it is symptomatic, non-simple, more than 5 centimeter, it is multilocular, it is bilateral, consider surgery. By surgery, we mean BSO, that is bilateral salpingo-oophorectomy, because she's a postmenopausal lady. Remember this algorithm by heart. You need to remember it to solve your questions. Now,
Ma'am, sorry, ma'am. Yeah, this is the second box where the size is more than 5 centimeter and it's not simple and patient is symptomatic. This is by laparoscopy.
Yes. Laparoscopy salpingo-oophorectomy.
Okay. Thank
Or
you.
you can, that depends on the size of the cyst. If it is 10 centimeter, 15 or 20 centimeter, you may not be able to do it by the laparoscopy. Then you may need to do it by laparotomy. That depends.
Okay, okay, ma'am. Thank you.
Now we are going to repeat the reassessment that we discussed this point. That repeat the assessment in 4 to 6 months by doing CA 125, TVS, and TAS. Remember, now after 4 to 6 months, there can be 3 possibilities. Either the cyst is going to resolve. When the cyst is going to resolve, please discharge a patient from the follow-up. As simple as that. If the cyst either remains persistent or it is unchanged, now you are going to again do an assessment after 4 to 6 months. After 4 to 6 months, there are 2 possibilities. Either the cyst will resolve, so you can discharge the patient from the follow-up. But if the cyst gets changes in feature or it increases in size, you need to consider an intervention. Now, after the cyst, you need to remember 3 possibilities. Either it can resolve, it can remain persistent, or it can change in features. So if the cyst is going to resolve, it is you going to discharge the patient. If it is persistent, you're going to repeat the assessment in 4 to 6 months and they decide accordingly. Now, if the RMI score is 200 or more than 200, the patient is at high risk of malignancy, then you need to arrange for the CT scan, abdomen and pelvis. Remember this point, that when the RMI is more than 200, first you need to do the investigation, that is the CT scan, then you need to refer the patient to the gynae oncology team. Now, in the oncology team, the MDD team, that is the multidisciplinary team, they will review the patient that whether she is at a high risk, high likelihood of having ovarian malignancy, or she is at a low likelihood of having a ovarian malignancy. Now, if she is at a high risk of having a malignancy, the laparotomy will be done. In both cases, if she is having a high risk or low risk, you will do the laparotomy. Now, what is the difference? That we have just discussed this. That is, it is going to be full staging laparotomy by a trained gynecological oncologist. But if she's a low risk of malignancy, you will do TH plus BSO, omentectomy, peritoneal cytology by the suitably trained gynecologist. Remember this. Both will be laparotomy. The difference is that it will be done by the oncologist and it will be full staging. In this, you will do the pelvic clearance. Along with that, it will be done by the gynecologist. Am I clear to all of you? All my points are clear?
Yes.
Yes, ma'am.
Thank you so much. Shall we move ahead?
Yes, ma'am.
All right, okay. Now the next that we are having, it's a recent talk article. Just a second, I can see. Now, the next topic is the management of ovarian cyst in children and adolescents. It's a new talk article from April 2020. Now, ovarian cysts, they can be seen in the girls and women of all ages. In children and adolescents, they commonly present either during the neonatal period with a peak incidence in the first year of life or around the time of menarche. Most of the cysts, they are benign and they will resolve spontaneously. They can present with pain, but usually they are an incidental finding. So you need to remember that in the childhood and in the adolescence period, in the neonatal period, most of the cysts, they are benign. Now, cyst can be either the neonatal cyst, it can be simple benign cyst, or it can be a complex malignant cyst now, and then we are going to discuss the management of those cysts, how we are going to discuss them, follow them. Now, ovarian cysts are the most common cause of abdominal cyst in the female fetuses and the neonates, especially presenting in the third trimester. Most of them, they are unilateral, simple in nature, and they can be of varying size. The cause is the fetal gonadotrophins, maternal estrogen, or placental HCG. Now, what are the complications? We all know the complications we have already discussed. It can be torsion, rupture, hemorrhage, or because of the cyst, there can be compression of the nearby structures. So some of the points will be repeating so that we will go through it quickly. Now, follicles can be seen in 84% of the ovaries in girls under the age of 2 years. Most of these, they regress spontaneously, but it can take several months also. Now, management is often conservative and may involve serial scans, but if the cyst is large or if torsion is suspected, then surgical management is considered. And this surgery will be done by the pediatric surgeon. Remember, you need to remember that which surgery will be done by which person. This will be done in the neonates. Definitely, it's going to be the role of the pediatric. They are going to do the surgery if needed. Clear so far?
Yes, ma'am.
Yes, ma'am.
Thank you. Let's move on. Now, what are the benign ovarian tumors? Most of the ovarian cysts in children and adolescents, they are benign in nature, with 60% being functional simple cyst. You need to remember it's a quite big figure, that is 60% are benign. Here, the ovarian follicles, they fail to involute and mature into the corpus luteum. They are thought to be caused by the intermittent gonadotrophin production by the developing pituitary gland. Most of the functional cysts, they resolve spontaneously. In premenarche girls, the incidence is 1.8 to 15%, and the incidence increases with the age. Simple ovarian cyst rupture is a common agnexal finding at laparoscopy for an acute abdomen in young girls. Often it requires no intervention. So most of the functional cysts, it is one of the most common cysts in children and adolescents. They're benign. They're common. They have an incidence of around 60%, and they resolve spontaneously. Usually they do not require any treatment. Now, mid-cycle pain in a post-menarche girl is often associated with a functional hemorrhagic cyst. Remember this, that whenever we are in the cycle, the cyst that is formed is a functional hemorrhagic cyst. These may be associated with some free fluid or hemoperitoneum, but most of them it resolves spontaneously. Now, what are the complex benign cysts? Germ cell tumors are the most common tumor in children and adolescents. Now, how much they are common? 55 to 70% are the mature cystic teratoma, that is the dermoid cyst. They usually occur between the ages of 6 and 15, and 10% may be bilateral. Remember this 10%, that 10% of the dermoid cysts, they are bilateral. There's an SPA on it. That 10% are bilateral. The complex benign cysts, they're usually asymptomatic and they're also discovered incidentally on a scan. 15% of the dermoid cysts can present with abdominal pain and torsion. Sometimes there's a spontaneous rupture of the mature cystic teratoma. It occurs in less than 1% of the patient, and malignant transformation is reported in approximately 1.7%. You need to remember this point, that germ cell tumors are the most common, out of which teratomas, that is the dermoid cysts, they have an incidence of 55 to 70%, out of which 10% are bilateral and only 1.7% can be transformed into malignancy. Quite a percentage is in I've been discussing. Please write it down so that you don't forget it, so that you can easily revise it at the end, just for your revision. Now, what are the complications of the dermoid cyst? They can cause carcinoid tumor, stroma ovarian, hemolytic anemia, and anti-NMDA receptor encephalitis. Now, what are the type of ovarian cyst and neoplasm in children and adolescents? That is, we've already discussed. Benign are the most common. Malignancy, they compromise 4 to 16%. Simple cyst, functional cyst is 60%. Complex cyst, what are the examples of the complex cyst? It can be mature cystic teratoma, that is dermoid cyst, endometrioma, gonadoblastoma, serous adenoma, mucinous adenoma, cystic adenoma, fibroma. Or sometimes there can be ovarian torsion, there can be abscess, there can be paratubal and paraovarian cyst. By malignant, what I mean, that they are sex cord stromal tumors, that is juvenile granular cell tumor. It is the most common one in the malignancy. And the other one is the Sertoli Leydig cell tumor. Other examples of germ cell tumor include dysgerminoma, embryonal carcinoma, yolk cell tumor, and immature teratoma. In terms of epithelial tumors, it is serous adenocarcinoma and mucinous adenocarcinoma. You just need to remember whatever a few of the examples you can remember. There's no hard and fast rule in this. Just to you can understand whether it is a benign or the malignant, just for that purpose only. You can remember the most common ones. That is a juvenile granular cell tumor. Now, what is gonadoblastoma? It's an example of a mixed germ cell tumor that characteristically develops in gonadal dysgenesis when there is a presence of Y chromosome. Although it is benign, it can evolve into dysgerminoma with malignant features. It is generally a benign, but it can convert into malignant features. Remember this. Now, what are the malignant ovarian tumors? We've already discussed that the most common is the juvenile granular cell tumor. Almost half of the malignant ovarian tumors in children and adolescents, they are juvenile granular cell tumor. They are solid tumors and they are the most common form of sex cord stromal tumor. Half of them are diagnosed between the age of 6 and 13, and 1/3 they are diagnosed between the age of 14 to 19. Over 95% of the patients present with a tumor limited to the ovary, and they have more than 90% survival rates with surgical resection alone. You just need to remember that the most common malignant ovarian tumor is juvenile granulosa cell tumor, and it is an example of sex cord stromal tumor. We have already seen in this. That is an example of sex cord stromal tumor, the juvenile granulosa cell tumor, and it is bilateral in 2 to 5% of the cases. In most of the cases, it is unilateral. And the most common presenting feature is precocious puberty. It causes precocious puberty. What do I mean by precocious puberty? It can cause enlargement of the breast enlargement. It can cause pigmentation of the areola, vaginal discharge, and pubic hair growth. Why it happens? Because it secretes estrogen. It's an estrogen secreting tumor, but sometimes it can present with excessive androgenism, such as clitoral enlargement, hirsutism, deep voice, irregular periods, or amenorrhea. Clear so far?
Yes.
Thank you. Now, continuing with the malignant ovarian tumors, they account for 1.5% of the ovarian cancer in Europe. 1/3 of the cases, they are dysgerminoma, other are the immature teratomas, and the other third include the embryonal tumors, endodermal sinus tumors, choriocarcinoma, and the mixed cell type. Most of the malignant ovarian germ cell tumors, they occur in the first 2 decades of the life. That is why early diagnosis and multi-agent chemotherapy, they are associated with high cure rates, and the risk of premature ovarian insufficiency is as low as 3%. Please remember this 3%. In cases of mixed ovarian germ cell tumor, it causes premature ovarian insufficiency as low as 3% because there's an SPA on it. Now, what is immature teratoma? They are defined by the presence of variable amount of immature neuroepithelium. Most of them are unilateral, but they can also be bilateral, or they have mature teratomas in the contralateral ovary. They can occur on their part or as a part of mixed germ cell tumor. Now, what are the findings? How will the children or the adolescents they can present? They can present either as an asymptomatic or as an incidental finding, which is very common. Pain is also one of the common symptoms. Abdominal distension or effects of abdominal mass, it is less common. Weight loss, polymenorrhea, menorrhagia, precocious puberty, these are the less common symptoms. And along with that, dysuria, constipation, leg pain or limp, it's an unusual symptoms. Fever, nausea, vomiting, back pain, they are seen with ovarian torsion. And so you need to remember only the most common one, that the patient can either present with asymptomatically or she can present with pain. These are the most common symptoms that the children and the adolescents can present. Now, what are the differential diagnoses? You need to remember only the common one, please. That in cases of neonates, the baby can have UTI, or there can be Meckel's diverticulum, most common one. Although all of them are listed, but remember only the most common one. In cases of children, the child can have appendicitis, gastroenteritis, constipation, UTI. These are the most common ones for the abdominal pain on the basis of the age group we are discussing. In cases of adolescents, they can be seen appendicitis, diabetic ketoacidosis, gastroenteritis, ectopic pregnancy, hydrosalpinx, PID, and renal calculi. You need to remember all of them in cases of poor adolescents, because these are the differential diagnoses on the basis of pain only. Now, in our children, what are the investigation that we are going to do? Remember, it is the transabdominal pelvic ultrasound is performed in children and adolescents, and it is a sensitivity and a specificity of 94.4% and 98.2% respectively. So you need to remember in the children and adults, in the children and adolescents, the first line investigation will be transabdominal pelvic ultrasound. In cases of premenopausal women, it is going to be the transvaginal ultrasound. In cases of postmenopausal women, it is going to be CA125 and transvaginal ultrasound. Remember, the reason why I took this TOG article to differentiate you, to help you differentiate between the three types: neonates, premenopausal, and postmenopausal. It is relatively easy to perform and it is also cost effective. However, it requires the full bladder to enable visualization of the ovaries. Ultrasound is helpful in differentiating benign from the malignant lesions that we've already discussed, the IOTA features. The transabdominal ultrasound scan of the abdomen and pelvis should be performed in the presence of an acute abdomen. If an adolescent has been sexually active, they could have a transvaginal ultrasound. Otherwise, always the first line will be transabdominal in cases of children and adolescents. Remember. Now, what are the tumor markers? In alpha-fetoprotein, it is raised in cases of immature teratoma, Sertoli Leydig cell tumor, yolk cell tumor, and embryonal carcinoma. Beta HCG, it is raised in cases of dysgerminoma and embryonal carcinoma. And lactate dehydrogenase, it is raised in cases of dysgerminoma and immature teratoma. CA125, we know that in cases of epithelial tumor, carcinoembryonic antigen, also in cases of epithelial tumors. Estradiol, as always in granular cell tumor, you need to see that estradiol will be raised. So estradiol is raised in cases of juvenile granular cell tumor, and for the testosterone, it is Sertoli Leydig cell tumor. So we have discussed the most common one that you only need to remember, that in cases of germ cell tumor, there will be increase in the levels of which tumor marker?
ASP, LDH, and HCG.
LDH, alpha fetoprotein, and beta HCG.
In case of granular cell tumor,
Estradiol and
inhibin and estradiol.
In cases of epithelial ovarian cancer,
CA125.
yes, exactly, excellent. Now we are going to talk in terms of management. So if a patient comes to you, if the patient is asymptomatic, she is having any pain in the abdomen, any problem with her menstrual cycle, or she is having precocious puberty symptoms, do the first line investigation as transabdominal ultrasound. Do the first investigation as transabdominal ultrasound. Now, what will be the size of the cyst? If the size of the cyst is between 3 to 5 centimeter, you will do the rescan in 3 months for reassurance, just for the purpose of reassurance. But if it's a premenarche girl, you can refer the patient to the clinic. Premenarche clinic is there, you can refer the patient to there. If the cyst is in between 5 to 7 centimeter, you need to see whether the cyst is asymptomatic or it is symptomatic. Because if it is asymptomatic, you will do the rescan in period of 3 months. If it resolves, it's finished, the story finished. But if you do this scan after 3 months and you find that the size is the same, that is 5 to 7 centimeter, then you need to arrange for the tumor markers, and MRI can also be considered. But if the same simple cyst, it is measuring 5 into 7 centimeter, but it is causing symptoms, then you need to do the tumor markers and the MRI, then consider laparoscopic ovarian cystectomy, or rescan in 3 months can be considered if patient is improving. If patient does not have any symptoms, then you can do it only. If, I'm going to repeat this point again, if the patient is having a simple cyst in between size of 5 to 7 centimeter, you have 2 options. If the cyst is asymptomatic, do repeat the scan after 3 months. If the cyst resolves, it's okay. If it does not resolve, it remains persistent, then you need to arrange for the tumor markers and MRI. However, If the cyst is simple, 5 to 7 centimeter, but it is symptomatic, then you need to arrange for the tumor markers and MRI. But if the
Ma'am,
cyst, yes, please.
ma'am, excuse me. For symptomatic cyst, we go for management, not for further workup. No?
No, you directly cannot go for the work management. No, you directly cannot do this in any intervention. First, you need to find out, na? And then you are going to do manage with the cyst.
Is saying when we say that the patient, excuse me, when we say the patient is symptomatic, it means patient is having pain. And when the patient is symptomatic, we do treatment.
Yeah, we do treatment. So can't you give her simple painkillers?
Okay.
It is also one of the management options, na?
Okay, okay. If
And
there
once
is
you give them,
okay, thank you. If there is no cyst accident, we will go for further workup, right?
Yes.
Okay, thank you.
You're welcome.
Thank you so much.
And if the cyst is measuring more than 7 centimeter, you need to go directly for the laparoscopic ovarian cystectomy or rescan in 3 months. Remember, in cases of children, neonates, cyst can either fall into 3 to 5 centimeter, 5 to 7, or more than 7. But in cases of premenopausal, it is going to be less than 5, 5 to 7, or more than 7. The only difference is between this. If it's a complex cyst, you need to do the tumor markers. Which tumor markers? Alpha fetoprotein, beta HCG, LDH, CA125, and MRI as per requirement. If there is no suspicion of cancer, but the cyst is symptomatic, more than 5 centimeter, do laparoscopic cystectomy.
Excuse me, ma'am.
Yes.
Sorry to disturb you, ma'am. You just said if the cyst is complex, it's a complex cyst, we have to do tumor markers and MRI as required. Again, MRI, we'll go for MRI if the ultrasound is inconclusive, or we'll definitely do an MRI.
No, not definitely.
Only
if it is needed.
Ultrasound is inconclusive.
Yeah, if you feel that you have the need or the ultrasound is inconclusive, then you will do it. Otherwise, no.
Oh, thank you, ma'am.
Okay, you're welcome. So if there's no suspicious of cancer and if the cyst is symptomatic, you can go ahead with the laparoscopic cystectomy. However, if the cyst has any features of suspicious of cancer, please refer that patient to the gynecology, oncology, MDT team. The multidisciplinary team will deal with this child. Gynae and the oncology multidisciplinary team. Now, all children and young girls should be followed up after the surgery to discuss the findings and implications on the future fertility. But if the patient presents with an emergency acute abdomen because of torsion, rupture, or hemorrhage, we need to inform the pediatric surgery if available within 4 hours of admission and the clinical condition permits. Then, laparoscopic surgery where possible, ovarian sparing surgery, requesting the on-call gynecologist for the input. Remember, whenever we can preserve the ovary, we need to preserve the ovary because she's a young child or a young adolescent. She needs to begin her family. So preservation of the ovary is very important. Our aim is to preserve the ovaries. But if it is not possible, then definitely we have no other option other than removing the ovary. Is this algorithm clear to all of you? It's very important. If you understand this, the whole management you have covered.
Yes, ma'am.
Great. Now, in what are the surgical tips for laparoscopy in children and adolescents? Now, you need to make sure that the bladder is intraperitoneal in children, so care with suprapubic ports. If the age is less than 10 years, catheterization should be done to avoid urethral trauma. Thin child, which will have the aorta just beneath the skin, careful with skin incision and lift the umbilicus before the incision. Aorta is only 2.5 centimeter in thin patients, whether it is a child or a thin adult. Remember that aorta is only 2.5 centimeter below the skin, abdominal skin. And in cases of pneumoperitoneum, it should be kept at a 12 to 15 millimeters of mercury for thin adolescent, younger children. But the younger children, it may require more lower, that is 8 to 10 millimeters of mercury. And fascia is not well developed and prone to port site herniation. Use a smaller scope that is 2 to 5 millimeter. Use a small trocar and close the fascia that is by 10 millimeter and more port size. Keep the camera in the port as the umbilical port is removed to prevent omental visceration. And also avoid vaginal examination, uterine manipulation in adolescents unless necessary during the procedure. Now, in terms of anesthesia, that be mindful of the effect of intraperitoneal carbon dioxide under pressure and its limited effect on the lung capacity of the child. So you need to, in terms of surgery, you need to remember that if the child is less than 10 years, you need to catheterize the patient. You need to catheterize the child, and aorta lies only 2.5 centimeter below the abdominal skin in cases of thin children and as well as adolescents. You need to maintain the pneumoperitoneum in cases of young children in between 8 to 10 millimeters of mercury. In cases of adolescents, thin adolescents, in between 12 to 15 millimeters of mercury. Now, ovarian cysts in children and adolescents, they are most often functional cysts. They usually do not require any intervention. Of the ovarian tumors, benign mature teratoma, that is the dermoid cyst, are the most common with low overall risk of malignancy. Whenever it is required, surgery should be laparoscopic with ovarian conservation whenever possible, even in cases of ovarian torsion. In complex ovarian tumors with suspicious of malignancy, the involvement of gynae-oncology, pediatric oncologists, surgeons, and a multidisciplinary team is essential. So in general, a more education and advanced screening skills are required for gynecologists in the management of children and adolescents. Is this talk article clear to all of you?
Yes, ma'am.
Yes, ma'am.
Great. Any questions before we move ahead?
Clear, ma'am.
Clear. All right. Okay, great. So shall I ask you a few questions now?
Yes.
Yeah.
Yes, ma'am.
Okay. Mm. Who's going to take the first question? Who's going to take the first question?
Shall I take ma'am Shaista?
Yes, sure, please. Yes, just let it. Yeah. Okay, can you read the question, please, loudly so that everyone can hear?
Ma'am, we can't see the question.
Oh, you can't
It is
see?
not visible.
Oh, I'm
Not.
just let me check. Why is it so?
We are seeing thank you.
Are you able to see now?
No, ma'am. We are seeing thank you.
Smiling face. Now brainstorming.
Yes. Yes,
Okay.
brainstorming.
Yeah. Okay. Yeah. So the first question is here.
Miss XY is 64 years old, postmenopausal. Her recent ultrasound scan reveals the presence of 4 centimeter right ovarian cyst. The cyst is multiloculated and shows the presence of solid areas. There is no free fluid. The left ovary is normal. Her CA12550. She has been explained for her RMI results. What is her RMI score based on the information provided? So, ma'am, she is 64, menopausal. So this is 3, and ultrasound 4 centimeter right ovarian cyst. This is multiloculated and shows pre and solid area. So these are 2 findings. So this is also 3, and there is no free fluid. Left ovary is normal. Her CA125. This is 50. So RMI scoring, ma'am, 950. 450.
Yes, exactly. Excellent. The correct answer is 450. Claps for all of you, Sidra, Sonia, Salma, Shazia, all of you. Yeah, you all are correct. Excellent. Yeah. So who's going to take the next question?
Me, please.
Who is this?
Sidra.
All right, Sidra. Yeah, sure, please.
Miss XY is 64 years old, postmenopausal. Her recent TV ultrasound scan reveals the presence of a 4 centimeter right ovarian cyst. The cyst is multiloculated and shows the presence of a solid area. There is no free fluid. The left ovary is normal. Her CA125 is 50 units per ml. She has been explained of her RMI results 450. Which of the following treatment options are best suited to her? Laparoscopy and bilateral salpingo-oophorectomy, laparoscopy and right salpingo-oophorectomy, laparotomy and staging procedure, including THBSO, infracolic omentectomy, MRI abdomen pelvis, and PET scan. Laparoscopy and bilateral salpingo-oophorectomy.
Your answer is?
Ma'am, it's C, laparotomy and staging procedure, including THBSO and infracolic omentectomy.
Excellent. Because
Her
the RMI
RMI
score is
450.
more than 200. So we always go for laparotomy and a staging procedure.
Yes.
All the options are wrong. Am I right?
Yes.
Excellent. And who is going to take the next one? All are correct. Yeah, all answering very correctly in the chat box. Who's going to take the next one?
Yes, madam.
Yes. Yeah.
It is recommended that RMI should be used to triage postmenopausal women with ovarian cysts to assess low, moderate, or high risk of malignancy. This is calculated as ultrasound score multiply menopausal status and CA125. What is the risk of ovarian malignancy in women who has a RMI 25 to 250 moderate risk? Now it's 75%.
Paras, I'll give you one more chance to think.
Okay. No. Low risk के लिए 20%. Sorry.
Yes. For the low risk, it is how much?
20%.
For the low risk,
less than 3%.
yeah, there's 3. If it is moderate risk, yes, correct, to 20%. If it is high risk, that is 250, 75%.
75.
Yeah, exactly. All are right. Yeah, answering correctly in the chat box. Who's going to take the next one? We'll take the next question.
I will read.
Okay. You need to read and answer it also.
I'll try.
Okay. So now EMQs are there.
Please, everyone mute your mics, please.
I'm muting everyone. Then please you can unmute yourself. Okay.
Please move on.
Ma'am, please unmute yourself. Mute yourself.
I'm so sorry. I didn't knew that I muted. I was speaking. I'm so sorry for that. Yeah, who's taking the first question, please?
Actually, I read the questions, so I
I'm
will
so
read
sorry.
it now
Yeah.
again. No
Yeah,
problem.
sorry. I'm so
Okay. Okay. A 65-year-old woman has an incident finding of an ovarian cyst during an MRI scan to evaluate her spine. A follow-up ultrasound confirmed this to be a simple cyst with a maximum diameter of 4.5 centimeter. Her serum CA125 is 5 international unit. The woman is asymptomatic. So can we see the options?
No, first, what are you going to mark?
Yes, we are thinking that we should repeat the scan after 4 to 6 months.
Correct.
Okay, let's go
And
to the options.
CA125 as well.
Okay, let's go to the options.
Arrange follow-up scan in 6 months time. Arrange follow-up scan in 12 months time. Chemotherapy, combined oral contraceptive pill for the 6 cycles. Full staging laparotomy, gonadotropin releasing hormone analog for 6 months. Laparoscopic cyst drainage, laparoscopic bilateral salpingophorectomy, laparoscopic ovarian cystectomy, laparoscopic unilateral oophorectomy, laparotomy, bilateral salpingophorectomy, and omental biopsy. Measure serum CA125 and calculate the risk of malignancy index. No treatment required. Radical hysterectomy, including lymph node dissection. Arrange follow-up scan in 6 months' time. Dr. Aqsa.
Yes, I can hear you. Yeah.
Yeah, so this answer is
Yes, this is the correct answer. Arrange follow-up in 6 months' time. You're very right. Exactly. Who's going to take the next one now?
If nobody is reading, can I?
Yeah, sure.
If anybody is volunteer, no problem.
Yeah, please, anyone who is, whoever does it. You know, we want you all to be more active now.
Okay. A 65-year-old woman is referred urgently with weight loss. A 65-year-old woman is referred urgently with weight loss, abdominal bloating and urinary urgency. An ultrasound scan demonstrate a multicystic mass with the solid areas and ascites. A serum CA-125 is 100 international unit. A CT scan confirms suspicious marks. Which management should be recommended by the multidisciplinary team?
Staging report. Ma'am, please go to the options.
Yes, but I want you to tell me first. Then I'll go. Yeah, exactly. So now
Full
search the
staging
option.
laparotomy.
Full staging laparotomy. Yeah, now you don't need to read the whole options again. Just find your option correct there and mark it. And you're done with the EMQ.
Staging laparotomy, yes.
Full staging laparotomy, right. Excellent. Who's going to take the next one?
Finish both.
Yeah, we have. Yeah, I have the next EMQ for the questions of it.
Ma'am, if no volunteer, then me.
But please ask them. Nobody should write the answer before. Let answer
So you don't
think
go
about.
back to the chat box and see it.
No, I'm not going, but it is coming directly, and if they are writing, it will show. It's not like if I am not. I'm not going to put anything.
Okay.
Never mind.
Madiha, Noor, anyone? Priya?
Okay, ma'am, I want to read it.
Who is this? Priya? Yes, please go ahead.
A healthy 60-year-old woman with a BMI of 28 presents with lower abdominal pain and bloating. An ultrasound scan demonstrates a unilocular cyst of 4 centimeters with a solid component. There is no ascites. Serum CA-125 is 40. So it's like 3 into 40. 20 into 1.
So what shall we, investigation?
No, investigation is given to you. You have to choose the management option.
Her BMI is less, her RMI is less than 200.
Her RMI is less than 200?
It's 40 into 3 into 1.
Why 1? Why 1?
RMI would be 0.
RMI, you are saying ultrasound component is 1?
Solid component is there.
Unilocular?
Ultrasound component should be 0 now.
Why 0?
No 0, it's 1.
Oh, it's 1 solid component.
Solid component is 1. So 1 into 3 into 40.
Yeah.
120. So RMI of 120 becomes.
So what is you going to do the management?
Can I see the options, ma'am?
Yes, sure. Everyone is writing correctly. The chat box.
They would like to do a lab bilateral salping of oophorectomy. She's symptomatic and is already postmenopausal.
Yes.
Sorry, can you repeat the option for me?
Laparoscopic bilateral salping oophorectomy, since she's postmenopausal and symptomatic.
Yes. You're very right. Excellent. Now, who is going to take the last EMQ for today?
Ma'am, I will take Chanda.
Okay. Yeah.
A frail 90-year-old woman present with abdominal discomfort and bloating. She has mitral stenosis and atrial fibrillation. She has urinary frequency and nocturia. An ultrasound scan reveals a 10 centimeter simple ovarian cyst. Her serum CO125 is 2 international units per liter. RMI score. Do I need to calculate RMI?
Yes, you need to, because you need can tell me the management, no?
Yeah. 3 into 10, 3 into 2, 6, and size 26, 60. RMI is 60, but for symptomatic relief, we should do cyst aspiration.
We don't do aspirate. What we do? We never aspirate the
Cystectomy.
cyst.
Laparoscopic ovarian cystectomy?
No. It is.
Cyst drainage? No, we are not draining cyst.
Yeah, we drain the cyst. We never aspirate the cyst. Remember, the reason why this give this last EMQ was the reason to tell you that we never aspirate the cyst because it is a very high recurrence rate. Remember?
Ma'am, what is the difference between drainage and aspiration?
You know, you drain the cyst completely. In aspiration, you aspirate. You can sometimes, you usually do it under the ultrasound guidance, but sometimes when you aspirate the cyst, the content may be left. But when you drain it, it is completely cleaned from the cavity.
Ma'am, she is 90 years old.
It's ultrasound guided cyst drainage.
Yeah. Drainage, aspiration, it is always ultrasound guided.
Okay.
What is the last
Is
option?
risk malignancy index will be 0?
Why 0? She is 90 years.
Cannot be
She's
0.
90 years. 3. It
to
becomes 3. So it cannot be never be 0. 3
No,
into
3 for postmenopausal, 2 for CA125, but there is no score for ultrasound.
So we consider one.
So we
It's simple cyst.
It's just a simple cyst.
6.
So her RMI is 6.
No, in this
How
we don't
could it
have
be
to.
6?
No, the ultrasound
In
score
this
is 0.
question,
It's 0.
in this question, we don't have to calculate the RMI. We have to tell the management option. But if I
But
ask
ma'am,
you,
in case we have to calculate the RMI, won't the RMI be 0 because there are no ultrasound features?
Then the RMI is going to be 0. If we have to calculate the RMI for this lady, it's going to be 0.
Ma'am, in both the questions, RMI is international units per ml. And here it is given international units per liter. Don't we have to convert it?
No, it doesn't make difference. Because that is the report that has been done for this patient. That is the result we have been given. We don't need to do any change to that.
Okay.
Clear?
Yes, ma'am.
Previous question is it is a premenopausal cyst.
Sorry?
Just the previous question. If it is a premenopausal cyst, like question number 22. If it is a say 24-year-old.
She is not premenopausal. All are postmenopausal.
No, for just for another
practice question. If it is a premenopausal, now what will be the answer?
So you are going to tell me what is the answer. I'm not going to tell you anymore. You are going to tell me the correct answer.
Can I give the answer?
Yes.
It will be further imaging or surgical intervention.
Yes. Definitely.
Is it further imaging or referral now?
Why you
No,
are
if
going to directly refer?
simple cyst more than 7 centimeters, then further imaging or surgical intervention.
Dr. Aqsa?
Yes.
I want to clear one thing. In the last question, there is ultrasound finding is not given. Like it is saying that the patient is having simple cyst. So we are considering here ultrasound score is 0.
Yes. Because out of the 5, there is no any. Out of 5, you don't have any multilocular, metastasis, solid areas, ascites, and bilateral. You don't have any of the features, so it will be 0.
Okay.
No feature 0, 1, 1. Any feature between 2 to 5, your score will be 3.
Okay. Thank you.
So shall we end the session?
Okay, ma'am.
Thank you. Thank you.
Yes,
Thank you so much.
Thank you so much.
Thank you so much, Dr. Aqsa.
Thank you so much. Keep studying hard now.
Thank you.
Thank you very much, Dr.
Thank you.
Thank you very
See
much.
you very soon. Yeah. Please post your queries. If you have any queries, you can post it in the group.
What is the answer for the last question?
Last question. You are going to tell me.
I said it is a 6 months follow-up.
Why?
Every 6 months follow-up.
Why?
The reason is that this lady is a 90-year-old lady without any surgical fitness. First of all, she has frequency and nocturia. This frequency may be due to this simple ovarian cyst, which is pressing on the bladder.
But it is only 10. It is 10 centimeter. It's not a large cyst.
It's not a large cyst, 10 centimeter cyst, but for a 90-year-old lady, 10 centimeters sometimes may matter. And secondly, ultrasonological decompression or ultrasonological, this is not done except in pregnancy. Only in pregnancy sometimes it can be done, but this is not possible to do. Rather not necessary. It is of no use of doing it. So the choice may be in the next 6 months whether it is increasing or not. But at the same time, she has a frequency, urinary frequency, and nocturia. This frequency, whether it is because of compression or not, we have to see. Saying all these things looks like that we can wait for 6 months and go for a rescan to see whether it is increasing or not. If it is increasing, definitely it has to be removed. And if it is not, then we can wait.
Okay. Yes.
No.
But
If patient is symptomatic, how can we leave her for 6 months?
Yes, exactly. If she's having, you yourself is saying she's having complaint of frequency and nocturia, then how can you wait for this woman?
We just want to give symptomatic relief.
We need to relieve this lady by doing something for her.
Yes,
be generous
we
to
want to
lady.
give
Be
symptomatic
kind to
relief.
this lady. Don't be harsh on this lady. She needs your sympathy and empathy.
Years old. That is the question. She's a frail lady. She cannot go for a surgery. She's 90 years old. So
She already has mitral stenosis and atrial fibrillation. She's a very high risk lady.
And therefore, we should give a symptomatic relief by ultrasound guided cyst drainage.
Yes, exactly. And
Doctor, I need to
yes.
share the other question. That was 60 years, 20 BMI 28, and this was 4 centimeters solid component. So we do the whole surgery, hysterectomy plus BSO and all, because the cyst in postmenopausal women with a cyst with a solid component, she might be having malignancy. So why we are only doing BSO? Suppose after the biopsy, the results comes malignant, and she will be reopened.
Yes, sometimes that happens. What option you are saying for this lady?
What I feel that she should have a hysterectomy and BSO and staging, because she got a solid component.
No, solid component. No, you are not going to manage on the patient on the basis of solid component. You always manage the patient on the basis of RMI score. So what is your RMI score?
It's low, 120 is therefore.
If the RMI is less than 200, you need to do salpingo-oophorectomy.
Okay.
Ma'am, can you do frozen section?
Frozen section will be done in cases of laparotomy.
Yes.
But if you remove the ovary in a bag, and then you can send for frozen section, and according to the report,
yeah, that can be
malignancy
done. Yes, but you need to treat the patient according to RMI score. If RMI is less than 200, you need to do bilateral salpingo-oophorectomy.
Okay.
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 Yeah, thank you.
Okay, thank you everyone. If you have any queries, please post in the group. I'll be more than happy to answer all your queries. All right?
Okay, ma'am.
Thank you
so much.
Good night. Allah Hafiz.
Allah Hafiz. Thank you.
Good night.
Allah Hafiz, ma'am.
Yuvi, Putra, क्या करना है